Good morning, everyone. As we gather from the comfort of our homes, may we pause for a moment and reflect on the chaos and fear of the citizens of Ukraine. As a first-generation U.S. citizen of an immigrant family who fled from Soviet Russia, I cannot begin to convey how lucky I feel we are to have the freedoms and opportunities we have in this country. Let us hope and pray that the situation is quickly resolved and the citizens of Ukraine can safely return to their homes. I want to welcome all of you to the 44th Legislative Breakfast on Mental Health. My name is Max Shafir, and I serve as the chair of the committee that coordinated today's event. Like many others who have attended previous breakfasts, I'm missing the good food and chance to gather with friends and colleagues at the Friday Center. Hopefully, we can come together in person next year, so please mark your calendars for Saturday, February 25th, 2023. As Senator Mike Woodard will note in his remarks later today, this virtual event is only possible due to the technological savvy of the Friday Center. A big shout out to Bart Smith, as we are very appreciative of all their skills. We also want to give a big thank you to the National Association of Social Workers of North Carolina for being a major sponsor of the breakfast, and the Wizards who helped coordinate all of our registration. Earlier this morning, sponsors, legislators, and speakers gathered for the virtual orange juice reception. I want to give another big thank you to Representative Greg Meyer and Valerie Arndt from the NASW for co-hosting our guests, as well as to Josh Lozoff for his brilliant performance. A digital program was embedded as a link in the email sent earlier today to all our registered attendees. It includes the agenda, biographical information of presenters, honorees, companies, and organizations who provide sponsorship support for the breakfast, as well as a feedback survey and information on how you might be able to win a special magic show by Josh Lozoff himself. It's an extra incentive to stay until the conclusion of the event at noon, so don't disappear on us. In this digital world, staying in touch with everyone is a major task, so I want to give a big thank you to Ali Coots of CEI, Create, Engage, and Inspire Media, for designing and producing our online announcements, digital program, and for keeping the world updated on the 44th Legislative Breakfast on Mental Health. A special acknowledgement to Dr. Mandy Cohen, who updated us at previous breakfasts and whose strong advocacy for whole person health services has helped promote and expand Medicaid eligibility. We send our best wishes to her in her new endeavor, and today we welcome her successor, Secretary Cody Kinsley, as our keynote speaker. Finally, a big thank you to all our panelists, award winners, recipients, speakers, for all their hard work that they do every day to ensure that change can occur throughout the mental health care world. Thank you to all of you for your commitment, advocacy, and optimism to help create and influence our system. And again, thank you to everyone on this virtual meeting today. It's a huge opportunity to have this many individuals together for our 44th event. Now that we've thanked everyone, I want to remind all of us why we're here. We come together every year in hopes to inform, collaborate, and create opportunity for change within our mental health care system. Today, we've got a long list of legislators, experts in the field of mental health, as well as executives of MCOs, providers that are all change makers that help the most vulnerable citizens in North Carolina. Please remember that each of us carries the responsibility to change the lives of those around us. And we make choices every day as to how we affect those lives. So heed the words of those that speak today and take what you can to create the catalyst of change in your own communities. I would like to introduce you now to a man whose humor and kind demeanor speaks for itself. Senator Mike Woodard has been active in community affairs for more than 30 years, including leadership roles with North Carolina JCs, his church, and a variety of local and regional groups. Please welcome to the virtual stage and our MC for the 44th Legislative Breakfast on Mental Health, Senator Mike Woodard.
Good morning. Good morning, Max. Thank you. And good morning to the over 200 folks who've joined us for the 44th Legislative Breakfast on Mental Health. I was thinking this morning, I think this is my 15th time attending this incredible event, and it was something I always look forward to. We're still meeting on Hollywood Squares, Zoom. I had a younger legislative friend on a call the other day, and I mentioned Hollywood Squares, and he looked at me like, what's Hollywood Squares? So I don't think he knew that. Of course, I remember the old Hollywood Squares with Paul Lynde and Charlie Weaver. Anybody remember Charlie Weaver? So just imagine me today as your Peter Marshall as we navigate Zoom. Because of the continuing challenges of the pandemic, we have got to be flexible and adjust. But Hey, you mental health professionals do that every day, so flexibility and adjusting are just natural for you. But while we've had to make adjustments, our commitment to advocate for mental health programs and behavioral health services hasn't diminished one bit. In fact, I would suggest to you that these last couple of years have just heightened our awareness of the many ways individuals and families are impacted by the difficulty in accessing and receiving essential services. So today we're going to learn from professionals who are actively engaged in providing services to persons impacted by mental illness. We're going to learn more about what realistic proposals are out there to increase awareness across or to increase access to services across populations and locations all around the state. What are some of the new approaches that are available here in North Carolina? And how do we expand lifelong support services that empower our service recipients? Before we get into the main part of our program, we want to recognize two important organizations who are responsible for helping coordinate and stage this 44th annual legislative breakfast. First, the North Carolina chapter of the National Association of Social Workers, who coordinated the registration, working behind the scenes and just doing an incredible job. So let's give them happy hands or clap for our friends in the Association of Social Workers. And as Max mentioned, we could not pull off this event without our great friends at the Friday Conference Center in Chapel Hill, and specifically Bart, who is working all the magic behind the scenes to make me look and sound as good as I possibly can. Y'all are beautiful already. So Bart, to you and your team at the Friday Center, thank you for making it possible for us to participate from our homes and some of you in your offices, and hopefully in very comfortable clothes. I have on a nice shirt, but I will not stand up to show you my comfortable pants. I also want to thank the members of the Legislative Breakfast Planning Committee who work so hard year round. You all see the 365th day of their work, but they will start again probably, we'll let them take tomorrow off, but they will already start planning for the 2023 breakfast on Monday. Probably with a debrief, like all good social workers, they'll debrief and then start planning ahead. So let's thank them. If you see them on the screen, kind of look at them and maybe do a little hand wave or something with your Zoom feature. You've already seen Max Scherfer, who coordinates so much of the work and is the visible face today, but working with Max on the committee, Jenny Gadd, Karen Kincaid Dunn, Linda Foxworth, Elizabeth Barber, Linwood Webster, and Linda Attic. And each person, all of you who registered for today's breakfast, you got a digital program. So I want you to just make sure you check your email and pull that up if you haven't yet, and have it next to you on your computer there, so you can see it for our agenda today, for the biography of all our presenters and our Q&A panel members. It also has an extensive list of all the legislators and other elected officials who registered to attend today. And that's a great resource for you because it has all of our names and contact information. So I hope you'll save the program so you can stay in touch with us throughout the year. And it also saves me having to worry about trying to introduce all those elected officials. That's the worst job any MC has. So let me pause here and thank all the elected officials who are here. We are not going to name you because you are in the dozens, but thank you to my legislative colleagues who are here, as well as our local elected officials, the city and county level. You all are so important to us on the front lines while we're busy in Raleigh. You are in your hometowns working on these as well. The program also contains a list of all the generous sponsors who underwrote the cost of producing this breakfast, and we can't thank them enough. Without their financial and logistical support, we could not do this. Now, first big event of the day is the presentation of our Lifetime Achievement Award. This award recognizes a member of the North Carolina General Assembly who has demonstrated continued commitment to promoting, supporting, advocating for improved and expanded mental health services. And I can't think of anyone greater to honor than the person that we do today. We were commenting earlier in the orange juice reception about the incredible things that she has done. I'm not going to tell you who it is just yet, though the program does, but instead I'm going to step aside and let Karen Kincaid Dunn, who's probably a constituent of this person, I suspect, but I'm going to step aside and let Karen Kincaid Dunn present the Lifetime Achievement Award from the Legislative Breakfast. Karen?
All right, thank you, Senator Woodard. Good morning, everybody. Today, we're honoring Representative Verla Ensko with the Lifetime Achievement Award at our 44th Annual Legislative Breakfast on Mental Health. Representative Ensko has served in the House of the North Carolina General Assembly since 1997. Back in the mid-2000s, when North Carolina was privatizing mental health services, providers were terrified when we were told that we had to transition our programs from our local area authority with no bridge funding. At the end of the legislative breakfast that year, Tava Mahadevan, who you will hear from later in the program, Linda Foxworth, and I literally accosted Verla in the parking lot in a state of panic, letting her know that we needed bridge funding to safely transition. Verla immediately asked, "How much do you need?" Her question caught us off guard, gave us pause, but we gave her an amount and she worked her magic along with the Honorable Ellie Kinnaird and secured funds that were critical for our programs to transition successfully to the new privatized structure. Verla, we could not have accomplished this without you. All three of these programs remain strong through the passage of time. Time is the gift that Representative Ensko has given to all of us, her constituents, her fellow legislators, her community, and most importantly, the individuals who deserve an effective, strong community mental health system. Representative Ensko has a long history of tireless advocacy for a well-developed, community-based system of care for individuals living with serious mental illness. She is noted for her progressive policy positions, believing in an activist government that provides for the common good and protects the vulnerable. Representative Ensko embodies the three elements of our program today. Verla is accessible. And when I say accessible, I mean accessible. She is responsive and proactive. She demonstrates effective care in her work by her communication with others, her passion to make a difference, keeping her mind and eyes open, and taking the time to make her community a priority. Verla has given a lifelong commitment to public service and our democracy. As Verla retires, she has set the bar high for what it means to serve in our General Assembly and work together for effective change. When asked about her decision to retire, she simply says, "It's time." Representative Ensko, on behalf of our extended community, it is an honor and a privilege to bestow upon you this Lifetime Achievement Award with a gift that symbolizes what you have given to us, the gift of time. Big hug, Verla.
Thank you, Karen. And thanks to everyone here. You've got an amazing number of people here today. And so 248, I see. That's a really wonderful attendance. And I'm so appreciative of everyone who's joined today and all the work that you do. This represents a huge group of people across the state that really focus on mental health care and all of the advantages that brings to the state. So I want to take just a minute to actually show you my award. This is a gift of time. It's a wonderful clock with a plaque on this side, and something that I'll be able to take with me wherever I go into retirement. And I'll remember all of the good years that we've had together. And I'll stay active in some way. Public service is really an important role. I'm a big supporter of democracy, and I think it's we all have to be engaged lifelong in our democracy. So I actually didn't get involved. I didn't run for public office to get engaged in mental health. I was not really familiar with the field very much. I was working with Governor Jim Hunt on Smart Start. I was the first board member in the Orange County Smart Start as that early education program got started. So I'm also have a warm place in my heart for early education, and ran for that, and then immediately got engaged in mental health as it emerged in early on in 1997. I think 1999, the Speaker of the House asked me to chair the committee that would look at our entire mental health system across the state. And Ralph Campbell, excuse me, who was the auditor at that time, had turned in a big report on mental health in North Carolina. And we had a committee that looked at that report and did a year-long study on it. And then we moved ahead with that initial reform. The reform has gone through many steps. A lot of you have been here. I call it an evolution of the program, and I believe that evolution is still going on. So early on in our system, in the early years, people with mental illness were taken care of by their families. Gradually, counties began to have homes. And so some counties, the larger counties, had group homes where people could stay and get some services. Then Dorothea Dix came along and started building institutions across the nation. And so we started having institutional care. And then under John Kennedy and President Johnson, we started getting federal money come into the state. And so when that federal money came in, the state had to have a way to disperse it across the state. And so some counties were too small to handle that themselves. And so we evolved into this area program where counties merged together to handle the federal money and the state money that was coming in. And so gradually, excuse me, in 2001 then, with reform, we turned those area programs. Remember the OPC, the Orange Person Chatham Mental Health Program? And we turned those into area programs and into LME MCOs, so that when we had area programs, the public system managed the money and hired the providers both. And so the transition with the LMEs is that they would become management of the money and hire private sector providers. And I think many of them still did some of the services themselves, but that was a big transition. And we had one LME MCO, Piedmont Behavioral Health, that you all remember, that did a great job managing the money. And so the state actually didn't trust the area programs to do that. And so they wanted to manage the money from the state level. And but the OPC had done a great job. And so they convinced the secretary to allow them to manage the money too. And gradually all of the area programs then were allowed to manage the money. And that was the LME MCOs did that. And so we now are in another transition where we're moving to whole person care. And I've been able to talk to a lot of the LME directors over the past few weeks to talk about future transitions, and so we may see more changes that come. And I think that's every year the system has solved problems, and so I depend on Wayne Sasser and some other people in the years ahead to continue to monitor all of that and to make sure that we stay engaged in making sure that people have the services that they need. It's been a wonderful experience. I've learned an enormous amount. I love to learn. So I think that's one thing that's really been a benefit for me it's like an education. So anyway, I'm very grateful for this award and for the many wonderful hours I've had with all of you. Many of you will be lifelong friends, and I'll see you around, and I will also remain active in the system. So thank you very much. I'm very grateful.
Hear, hear. Verla, congratulations. I hope you see the clapping and the happy hands that we're giving you as just a way of thanking you for your service to your constituents in Orange County and to the people of North Carolina. And congratulations on your upcoming retirement. You have taught us so much. I know you said you've learned a lot, but I can speak for me, but I see heads nodding of my legislative colleagues and our service providers of how much you have taught us. But we're not letting you slip away now. As you have said a couple of times this morning, you're still going to be available to us. We know you're just a phone call or email away because, as Karen said, you are so incredibly accessible, because we're going to need your knowledge and passion as we continue this work. Some of us realize there's a huge vacuum to fill, and those of us down on Jones Street are going to do our very best to carry on in your stead. So enjoy your retirement, Verla, and congratulations once again, and thank you from the bottom of all our hearts. Well, our keynote speaker for this morning's breakfast is no stranger to those of us on this call. He's been a frequent presenter at previous legislative breakfasts, and we have had the chance to work with him over these last 5 years in his role as the former Deputy Secretary for Behavioral Health and Intellectual and Development Disabilities at DHHS. But he got a job promotion about a month and a half ago, and is now our new secretary for the Department of DHHS. And before I formally introduce him, I just want to pause for a second and just recognize, Max mentioned earlier, the great leadership of Dr. Mandy Cohen in her 5 years as our secretary, and just so grateful for her work. However, in Mandy's retirement and moving from DHHS, she certainly hasn't retired, but in moving on, she has left the department in the very capable hands of our great friend, Cody Kinsley. Cody has hit the ground running. I know as a member of the Medicaid Expansion Committee, I have been in close contact with him as we work through that process. And he just continues his history of working so closely with the members of the General Assembly to find funding, to come up with programs, and harness just the desire and will to support prevention, intervention, and treatment services. It just shows his ability to work with folks all across this political spectrum, all across the state, and just to bring all these priorities together. You all in this provider community know him and his incredible work, and we are so fortunate to have him as our new secretary and to have him as our keynote speaker this morning. So please join me in welcoming our Secretary of Health and Human Services, Secretary Cody Kinsley. Good morning, Mr. Secretary.
Thank you so much, Senator. It is a pleasure to be here with everyone. And I'd first just like to extend my gratitude and congratulations to Representative Inscoe. When I started at the department, she was the very first legislator who summoned me to her office and had a whole list of things that we needed to do. And I believe that my response to most of that was absolutely. And she has been just a terrific partner and a terrific, thoughtful leader who has wanted to solve problems. And I could not agree more with her description of where we are. We will continue to evolve and change. Some of those evolutions and changes have not gone as well as others. We are committed to them going well. And I so appreciate her leadership, and we'll be keeping her on speed dial. Second, I just want to say, Senator Woodard, I believe last time I was here, you made a whole thing about my hair and the need to get it cut. And so, this morning I spent significant amount of time in front of the mirror trying to comb my hair just like yours. So I hope that I've captured the Woodard essence. And for those of you that remember, I'm sorry about my long lock of hair that maybe you were hoping that I kept. So it is a pleasure to be here with all of you, such wonderful friends here at the Legislative Mental Health Breakfast. And it's one of the best events of the year. And it's a real joy to come back to you and talk about this incredibly important moment as far as where we are, and in my new role as Secretary of the Department of Health and Human Services. As I begin my tenure, I do so with a deep commitment to the fact that behavioral health is core to health. I truly believe that without a comprehensive strategy to address behavioral health, we cannot make meaningful progress in advancing health for all North Carolinians. So it should not come to anyone, it should not come as a surprise to anyone that as we chart the path forward at the department, I, along with my team, have made equitably addressing behavioral health and resilience as one of the department's top 3 priorities. This, along with a focus on child and family well-being and building a strong and inclusive workforce, will help us organize and prioritize our work to improve the lives of our fellow North Carolinians. As we look to the future to accomplish this work, we are grounded in whole person health, driven by equity and responsive to the lessons that we have learned through the greatest health crisis in a generation. Some of those lessons learned include investing in strong collaborative partnerships, like what we foster here today, and building robust data systems that allow us to drive our decisions and to wrap our systems around people instead of wrapping people around systems. I believe that we can continue to drive forward in this transformation of our system of care by having thoughtful and collaborative embrace of change that makes a difference in people's lives. So as we reflect on the role mental health plays in our overall well-being and the influence that it has on our quality of life, I want to share a bit about where we are and how we recover stronger together. The data tells us that those with mental health conditions are more likely to have co-occurring physical health conditions. For example, depression increases the risk for many types of physical health problems, including heart disease, diabetes, stroke, pain, and Alzheimer's. Beyond the human toll, it includes families. And we know that there's a financial and economic cost paid by individuals, families, and society. On average, individuals with mental illness and chronic health conditions have healthcare costs that are 75% higher than those without mental health diagnosis. For those with diabetes, the cost of treatment can be 4 times higher when there's a co-occurring condition such as depression or alcohol addiction that is untreated. As we continue to promote whole person health and a whole health approach, we know the profound impact on the person and the pocketbook that behavioral health conditions have, and that we need to address those as we measure the overall wellness and stability of individuals, communities, and society. Less than 50% of North Carolinians entering treatment for either mental health or substance use disorder reported feeling good or excellent about the critical domains of life quality, such as housing, employment, their family relationship. In North Carolina, far too many individuals struggle with mental and substance use disorders. With 1.6 million adults meeting criteria for a mental illness, over 450,000 have a serious mental illness. Additionally, there's 390,000 children living with a mental illness in North Carolina, 232,000 of which have a serious emotional disturbance. 611,000 adults have a substance use disorder, and sadly, 32,000 kids do as well. I say all these numbers to emphasize the point that mental health is not a small issue that is relegated to the pennies found in the couch cushions and pushed to the fringe of society. We know that behind each of these millions of individuals are families and communities that also struggle as a result of these conditions. Our approach must be comprehensive, it must be swift, and it must be outcome-oriented. The department recognizes the need for a multifaceted strategy to address both the immediate and acute needs, as well as to prevent and intervene as early as possible. Much of our work is already underway. We're proud to have launched the new Division of Child and Family Wellbeing. Through the establishment of this division, the department is leaning in on the integration of behavioral health, physical health, social and nutritional programs to provide whole person care in a coordinated and streamlined manner to meet the escalating needs of children and their families. The Division of Child and Family Wellbeing brings together complementary health and human service programs that primarily serve children and youth under one division to promote cross-program initiatives and policy guidance to support North Carolina's children growing up safe, healthy, and thriving in nurturing and resilient communities. The division will play an instrumental role in addressing the needs of the 390,000 children living with a mental illness in North Carolina. We recognize these needs have grown tremendously during the COVID-19 pandemic. We've had a generation of children impacted, and our division is working hard with the Division of Mental Health, Developmental Disabilities, and Substance Use Services, and other divisions across state government to fully address the needs of children. When I talk about wrapping systems around people as opposed to wrapping people around systems, this is what I'm talking about. As with children, adults in North Carolina have experienced profound behavioral health effects from the pandemic, including 40% of adults reporting symptoms of mental health conditions and increased rates of substance misuse. Grief, stress, trauma, financial instability, and unemployment are all factors that contribute to one's mental health status. Even more troubling than the increased demand is the corresponding decrease in supply. The National Council of Behavioral Health notes that during the pandemic, providers experienced an average of 23% lost revenue. 65% of providers reported turning away, canceling, or having to reschedule appointments. The workforce challenges continue to persist, and they cause increased strain on an already stressed system of care. At DHHS, we are keenly aware of the backdrop here, and this only increases our focus and attention on these important issues. During the fiscal year 2020, just over 100,000 unique individuals received behavioral health or IDD services paid through state funds. 100,000 people paid for with state funds. As you know, these single stream dollars support North Carolina's uninsured population. And while I'm pleased that 100,000 individuals received the services that they need, or at least the start of those services, I'm troubled to know, considering all the numbers that I just mentioned, with regard to how many problems there are and how worse it is getting, that we still have over 1 million people that are uninsured through our state. I believe strongly that these dollars would be much better spent providing recovery and wraparound services, which we know are so necessary. The only thing that truly maximizes the use of these funds is closing the coverage gap. And we believe that the fastest way to move forward on that strategy is Medicaid expansion. It is not the only thing we need to do. And I am welcoming a collaborative conversation and thinking about all the ideas on the table to meet the many needs. We have an opportunity to increase coverage for 500 to 600,000 people. Those are individuals that we could provide important behavioral health services and more prevention services. And we could use state-funded services to provide the many things that Medicaid does not pay for that really ensures recovery. Our work for all of our priorities would be made better, stronger, and more sustainable with Medicaid expansion. It's not just an investment in people, it is an investment in the pocketbook. It supports providers, and it helps us move forward in the direction of prevention, where we can spend less dollars in managing people's chronic conditions and keeping them connected to care and having other supports, as opposed to spending all the dollars on crisis services, which is essentially where it goes. The need is there, and I believe that the time is right for us to come together and to create a North Carolina pathway to Medicaid expansion, opening up access to care for hundreds of thousands of friends, families, and neighbors. But even without Medicaid expansion, I'm proud of the work that the Division of Mental Health, Developmental Disabilities, and Substance Use Services continues to do to support a comprehensive array of prevention, early intervention, crisis, and community-based treatment strategies. Asking for help is a sign of strength. You see it on my purple screen behind me. And DMH has enabled a number of avenues to make help available to the public. This includes our Hope for Healer and our Hope for NC program and helplines that we stood up at the beginning of the pandemic to get ahead of the growing mental health concerns. Another hotline, of course, is our Problem Gambling Hotline, which is creating a portal where clinicians can connect financial coaches and counselors to better support their clients. Along that continuum of care, having a robust crisis response system is critical to reduce reliance on law enforcement and emergency departments through early and immediate intervention with trained behavioral health personnel. A crisis system, and this is important, a crisis system is truly effective when it is used to avert a crisis. The implementation of 988, the 3-digit dial to reach the National Suicide Prevention Lifeline, is federally mandated to begin in July of this year. At DHHS, we are working hard to ensure that we realize the potential of this number and to ensure that our crisis and healthcare system work for those who need it. With the implementation of 988, we're anticipating a call volume will be increased by 30% or more, adding significantly to the already 36,000 calls per year that the Lifeline receives. We recognize that this will require an expansion of existing systems and supports to meet the need. It will also necessitate a better data infrastructure to track and monitor bed availability and to be easily able to dispatch mobile crisis teams. The Division of Mental Health is currently in the process of creating that infrastructure, along with similar endeavors to grow our data infrastructure and analytic capabilities to once again drive our decisions and give us insight in how we can wrap programs around people. This is an effort that cuts through everything we're doing at the department. This, coupled with investments in a robust continuum of community-based mental and substance use disorder services, will help ensure that we are providing the right care at the right time in the right setting. We are doing that by investing in things like telehealth, so that medication-assisted treatment can be delivered through a whole patient approach, opening up access to rural and other underserved communities. We're also continuing to explore better ways to integrate care. Only when care is fully integrated can we truly achieve whole person care. DMH is funding models such as the Certified Community Behavioral Health Clinic model, which provides 24/7 access to integrated physical and mental health care services for those with substance use disorder and serious mental illness. And of course, we're working hard to successfully launch the tailored plans at the end of the calendar year, that continued progression of transformation that Representative Insko spoke about. These plans will truly embody the principle of care integration, which is so needed to move the field forward. Through tailored care management, behavioral health and IDD tailored plan beneficiaries will have a single designated care manager, supported by a multidisciplinary care team to provide integrated care management that addresses all of their needs. Integrated care truly is the way of the future, and I'm happy and pleased that our state is leading the way in this incredibly thoughtful and ambitious design. Sadly, we cannot have a meaningful discussion about behavioral health without addressing our justice system. This is an area I am particularly passionate about. And as Representative Insko mentioned, in the transformation where during a period of time, many facilities were closed without intentional investment in prevention services and a continuum of care, Many individuals with mental illness and substance use disorders have ended up in our jails and other incarcerated settings. We have so many opportunities to make changes that not only improve access to healthcare overall, but to improve access to services that puts health and wellness for North Carolinians at the center of all we do. Serious mental illness affects an estimated 14.5% of men and 31% of women in jails. 68% of people in jails have a history of misusing drugs, alcohol, or both. Compared to other North Carolinians, within the first 2 weeks post-incarceration, people who are incarcerated are 40 times more likely to die from an opioid overdose than the general population. The department has been bold in pushing forward various strategies, and you've heard me talk about them before across the continuum of justice involvement. Again, these investments are good for people and good for the pocketbook, giving people an opportunity to be on a different path, to provide services and supports that approach and address health and a pathway to employment and recovery that is lasting, as opposed to cyclical engagement in the justice system. First, we must do all we can to provide early diversion and alternatives to incarceration. Second, we have to provide care for those in incarcerated facilities. We must support their behavioral health conditions and care for the treatment that they need, and then provide them services at reentry to connect them to care overall. These investments are, again, very smart to help reduce the overall costs that we spend on this population when they cycle through jail and into the prison system. We've employed models such as co-responder teams in which behavioral health professionals are paired with law enforcement officers to respond to calls and de-escalate situations and avoid potential incarceration. We've also partnered with drug education agencies to divert over 800 individuals who have had first-time offensive to get needed education rather than incarceration. We have also provided care and treatment to individuals while incarcerated, included in the provision of medication-assisted treatment services that have incorporated meaningful reentry programs. I recognize that addressing behavioral health was already a challenge. Before the pandemic, we already had a strained and stretched system with millions in need. The post-pandemic era demands that we redouble our efforts. The time to act is now. I know the task ahead is great. I also recognize that by choosing behavioral health and resilience as a top department priority, I have chosen perhaps one of the greatest challenges our society faces. But I am eager to take on the challenge, and our team is as well. And I truly believe that we have no choice but to make this our collective priority. I am heartened by the knowledge that effective and evidence-based strategies exist, that treatment works and people recover. And we need to continue to invest in those services and those people. And I believe that strongly with the renewed focus and our commitment together, we can and we will make a difference for all of North Carolina. It starts here, it starts with us, it starts with you. Thank you so much for having me. I'm excited for today.
Secretary Kinsley, thank you for those incredible remarks. I hope you see the applause, and we are just so grateful for your leadership and for sharing your vision with us today. I wasn't going to bring up the hair, but since you started it, I had to put on my hat because we're trending on Twitter now, and you won the hair battle today. So I've got my Eno River hat on, and I wasn't going to go there, Mr. Secretary, but thank you. Those are beautiful locks. And, you know, the only reason I bring it up is because I'm jealous of the hair. So anyway, I'm going to stop there. However, I'm grateful for the amazing brain that's underneath that beautiful head of hair. And I'm also grateful for your heart because you lead with such compassion and passion in your work. And we're just so grateful to have you leading our great department and for working with your amazing team. So, Secretary, thank you. We all look forward to continuing our close work with you, especially as we work toward expanding Medicaid and so many other great initiatives that you touched on this morning. So thank you for taking the time to be with us today and for what you do every day. Well, you can tell I'm not in my office this year. Max wanted my funky clock. If you've ever seen my funky clock in my office, if you haven't, come by sometime. It's a treat. I'm in my den here in West Durham, just a couple of blocks from where my great friend and former colleague Paul Luebke lived. Paul and I were neighbors for over 30 years, and he is someone who influenced my work as an elected official, and was just such a great colleague. And the legislative breakfast has named our legislative champion award in honor of our friend, our champion, the late Paul Luebke. Last year's recipient of the Representative Paul Luebke legislative champion was my good friend, Mecklenburg Representative Carla Cunningham. And today, Carla is going to present the 2022 recipient of the Luebke Legislative Champion Award. Unfortunately, our recipient could not be here, but Carla's going to do a great introduction, and we will see a video of this year's recipient. Representative Cunningham, I'm going to turn this over to you to present the Paul Luebke Legislative Champion Award.
Thank you, and thank you all at the Mental Health Breakfast. So this year's awardee. In 2021, I was honored to receive the Representative Paul Luebke Legislative Champion Award on Mental Health. Today, it is my honor and pleasure to present the 2022 award to Senator Jim Bergen of Harnett County. This award honors the memory and achievements of the late Paul Luebke, who worked tireless in the General Assembly and the community to educate us all on the critical need of comprehensive mental health service. Previous recipients of the award are 2017 Representative Verla Ensko, 2018 Senator Tamara Barringer and Tommy Tucker, 2019 Senator Floyd McKissick, and 2020 Representative Josh Dobson. Senator Bergen carries on their example of focus and commitment in his dedication to address the inequities that continue and perhaps are even more evident today as North Carolina and the nation continue to face the challenge of living in a pandemic. We honor the senator for past achievement, but most importantly for his ongoing and forward-thinking work with staff at the Department of Health and Human Services and his fellow legislators in the General Assembly. With his leadership, we can work to ensure our most vulnerable community members receive safe and appropriate assessment and treatment, as well as supportive services to enable independent living and employment. Senator Bergen could not be with us today, and he has taped the following video to acknowledge receiving the 2022 Representative Paul Luebke Legislative Champion Award on Mental Health. Please join me in welcoming and honoring Senator Jim Bergen.
I want to thank Representative Cunningham for presenting me this award. I was online last year and saw her receive it, and it's just such an honor to be recognized at this breakfast. This is the first year that I've missed since I was elected in the Senate, and I'm so sorry I'm not able to be there with you. Mental health is one of my major priorities, and I look forward to traveling across the state, meeting with folks, talking about how we can move mental health forward. Again, thank you so much for this award. I look forward to working with you, and have a great rest of the meeting. Thank you.
Senator Woodard.
Oh, I'm sorry. Oops, sorry. I just got to get my hair back. Sorry, is Cody still here? I got to get my hair right. All right, anyway. Jim, thank you. As many of you all know, Jim is one of the hardest working members of the legislature. Jim, in absentia, we congratulate you for receiving the Paul Luebke Award. Folks, it's time to get into our discussions now, the meat of our meeting today. And our theme for this year's breakfast is building mental health policy for comprehensive, integrated, whole person care. So the next part of our program is going to be divided into three pillars or subject matter areas. And so the format for each of these pillars is a subject matter presentation that's going to be followed by input from 2 members of the General Assembly, then a Q&A panel, including the presenter and the 2 legislators. The incredible Rose Hoban is going to moderate the Q&As for each of these pillars. So pillar 1 is on access to care. Our presenter is Haley Shafir, a licensed clinician in mental health, substance abuse, developmental disabilities services. Ms. Shafir has authored articles on mental health and addiction, and she's the executive director of Therapeutics Incorporated, a company she founded to provide training tools and programs for counselors. Our General Assembly members who are going to be joining this particular pillar are Representative Pat Hurley and Senator Sidney Batch, 2 of our true advocates for mental health care in the state. So at this time, please join me in welcoming Haley Shafir, and she'll be followed by Representative Hurley and then Senator Batch.
Good morning, everybody, and thank you so much for the opportunity to come together. I'm very pleased to see so many North Carolina legislators and stakeholders come together to talk about mental health. I want to start my talk by discussing a somewhat loaded word, and that's power. Many associate the word power with the overuse, the misuse, and the abuse of power, which unfortunately we've all had to witness, especially over these past few years. It is definitely true that we find imbalances of power at the source of almost every inequality. Those with the least power often find themselves at the locked gates that deny them access to fundamental rights, resources, freedoms, and services. Without the keys to these gates, they can't get the things that they need to build a life of their own design. So essentially, having keys is having power, which is the ability to direct and influence the course of our own lives, and with a little bit more power, also the lives of other people. Recently, our culture has drawn our attention to the word privilege, but again, with a skewed definition. They've weaponized this word as a way to demonize those with more power and shame and guilt them if they didn't work hard enough to earn it or deserve it. Wouldn't it be more productive to instead ask those with the most power how, when, why, what, and for who they use it, and to demand more accountability for those with more power to use it rightly and responsibly? Those of us with the most keys are the gatekeepers, and this is absolutely a great privilege, meaning that it's an honor, a duty, and a responsibility to those on the other side of these gates. We can't just use our keys to open doors for ourselves and for those closest to us, to hide away our treasures or lock out people that we're scared might skim. In order to use our power rightly, we have to first recognize how much of it we have, which is why I ask all of you today to just make a mental tally of each of the following 10 statements that apply to you. So give yourself 1 point for each one of the statements that you would say applies to you. This exercise is designed to help you identify just how many keys you have in your pocket. Number 1, I don't live check to check and I have enough money or assets to buy the things I need and most of what I want. Number 2, I've got letters, credentials, or titles behind my name that give me credibility or access. Number 3, I could probably call in a favor or make a few calls to get myself out of financial or legal trouble. Number 4, if I tried, I could get in front of an audience of people to share my ideas, my knowledge, or promote something I care about. Number 5, I have built or been given connections and inroads that have helped me to get ahead. Number 6, I have the ability to affect policies or important decisions made at the place where I work or where I live. Number 7, I'm able to share my opinions and beliefs freely without having to worry about being censored, losing my job, or my livelihood. Number 8, the pandemic has not affected my ability to make a living wage or provide for myself or my family. Number 9, I have the means to access and afford quality health or mental health care for myself and my immediate family members should we need it. And number 10, If I really needed to, I could leave a toxic or abusive relationship, move to a safer neighborhood, take paid leave, or quit a job where I was being taken advantage of. So I would ask you all, how many keys do you have? Today, I have about 9, but I didn't always. I wasn't born into a life of privilege, and it's rare that I share the story that I'm going to talk about today. My dad was a member of the Yakuza who buried shoeboxes full of drug money outside of our home. He grew pot, he sold coke, and he had 5 of his fingers cut off before meeting an untimely death in his 40s. Years later, I also lost my mother to the disease of addiction, and it was these experiences which largely fueled my passion for this work. But before then, at the age of 14, I was institutionalized, given a handful of mental health diagnoses and prescriptions, and more than a few times, I literally found myself on the other side of locked doors. Eventually, I was funneled into the foster care system, bounced around, and then I aged out at 18. Unlike many 18th birthdays, it wasn't exactly a day when I went on a joyride with all of my friends to buy cigarettes and lottery tickets. It was literally the day that I had to start paying rent, looking for a new place to live, and figuring out how to be an adult. I had to work harder than many other people to build a better life for myself without much of a template support system or keys of my own. I did have some people who helped me, but those who made the most impact weren't those who opened doors or lent me their keys. They were people who saw things in me that I didn't see in myself and made me believe that it was possible to build a life unlike the one I'd known. I say this because today a lot of people without keys are being talked about and treated like victims, facing gates so sturdy and so high that they're told they shouldn't even bother trying to find their way in. Talks about privilege and guilt do little to actually empower people. And instead, they sometimes waste time that could be better spent unlocking doors and gates or having conversations with the people that hold the keys, the gatekeepers. And there are more and more people now who are on the outside of those gates than ever before. During the pandemic, rates of anxiety and depression tripled, suicidal ideation doubled, 80% of Americans reported being more stressed and isolated, and fatal overdoses rose 30% in 1 year. Millions lost their jobs and incomes, and unsurprisingly, those most affected were people with pre-existing mental health conditions, lower incomes, and minorities, children, teens, and young adults. In other words, those with the least power and the fewest keys. Still, there's a lot of data that shows that access to mental health care has improved somewhat during the pandemic. It's not perfect, but last year, 1 in 6 American adults sought counseling for the very first time. Nearly every insurance company expanded their coverage to allow patients to seek online therapy, making it possible for someone in rural North Carolina to find a therapist in Raleigh, in Greensboro, or Charlotte and meet with them online. New legislation made more Americans eligible for subsidized insurance premiums on marketplace plans, and many of these plans waived their copays for therapy. So while a lot of people lost their keys in these past couple of years, more doors were unlocked, allowing people to get services that they really needed. Life didn't give me a lot of keys, but I'm convinced that I'm braver and wiser and stronger because of that. I say this because I think it's important to note that those who have faced the most adversity don't want our pity, they want and they deserve our respect. After all, people who have experienced hardship, adversity, trauma, and mental illness have had to be strong in ways that most of us have not. So while we can and should open doors for them, we should always be working to help them build homes and families of their own, businesses of their own, and to find other places where the keys are in their pockets and not in ours. We can amplify their voices by giving them platforms to speak and be heard. We can pave inroads to home ownership, safer communities, college educations, higher paying jobs, and better schools for their kids. But most importantly, we can stop viewing them as different from us, because differences become divisions that further inequalities. Remember that improving access to mental health doesn't just mean funding programs and expanding eligibility. It also means granting people more access to us. not just to lead them, to lend them our keys, but also our time, our attention, and our compassion. In closing, Richard Rohr once wrote, "Sooner or later, we all believe the world's version of who we are." So seeing and treating all people as our equals is one of the best uses of our power, the way to use it rightly and responsibly. So with that, I would like to thank you, and I would like to issue a warm welcome to Representative Pat Hurley from Randolph County.
Thank you so much, Haley. It made me look at power a little differently this morning. I don't know how many keys I have, but I do know that I care for those who need the help that we need to make sure that they receive, and especially those with that are born with disabilities and parents who want to keep them at home. I think they need every thing that we can give them. I am from Randolph County, and it is one of 11 counties that's in the Sand Hills Center district. And we have 10 other counties, which are Anson, Davidson, Guilford, Harnett, Hoke, Lee, Montgomery, Moore, Richmond, and Rockingham. And when I was looking at this today, thinking about what to say today, I couldn't help but remember back when I first became a legislator back in 2000. I was elected in 2006 and came in 2007. And I had so many calls from people who needed mental health help. And my best friend's brother had Down syndrome, so I had grown up with being in his family. They were like my family too. They took me in as my parents. They even gave me my cake cutting, and I spent the night there the night before my wedding. But seeing him and watching their family and seeing the things that they did, I have been aware of differences for many years. But back then, in 2007, even when they were starting the new reform, which didn't turn out, it's absolutely 100% better today. But at that time, they did it too quickly, and they left people, Randolph especially, who had great mental health people, Maisie Fleetwood and different ones Ann Shaw, that knew what they were doing and had helped the mental health at that time. And it was working so well in Randolph County. So when they did the reform, which it didn't fill in the places that it should have filled in. There was no phone number for anyone to call. So jails and hospitals and law enforcement and different people were really tested at that time. Children were being sent out of state. And I think some are still having that situation now, which was so wrong. I mean, to get them away from their families was really, really bad. The hospitals, I remember I was called one time. They allowed me to come in. A man was really bad off, and they could not find placement for him. And just to talk to him and to realize how important a place, and Victoria Witt, she has been a blessing for Sand Hills, and she would try to find a place to place someone who really needed help at that moment. And some of them were in there for 2 weeks, even longer, and some of them strapped to a chair or in the hallway or whatever. I haven't heard of this lately, thank the Lord. And I'm so thankful that we have better access. And I'm so happy that in our Sand Hills Center, we now, and I thank goodness that we did this, by allowing LME and MCOs to use reinvestment funding for crisis options. We are expanding the availability of hospital diversion services in local communities. In Randolph County, reinvestment funding was used to build a comprehensive behavioral health center. And in that center, it's called Daymark, and it's been used before for different things, but it's now offers behavioral health urgent care with 23-hour chairs for assessment and referral of individuals in behavioral health crisis, along with 16 adult facility-based crisis beds for mental health and substance abuse needs, and offers outpatient services, including medication management. This comprehensive model serves as a diversion from hospitalization, with more than 95% of those using this service over the past few months not needing hospitalization within 30 days of the service. Excuse me. Sandhill Center has used reinvestment funding. Excuse me again. To add an additional behavioral health urgent care in Richmond County and a child facility-based care unit in a child facility-based crisis center is planned for Richmond County when the license for the facility is finalized. Crisis intervention training is a 40-hour law enforcement training that has been embraced across North Carolina to increase law enforcement officers' understanding of behavioral health and understanding of local community services. Others have learned this too, because it's so important that they know when a person is in crisis through health or through being a criminal. CIT is a partnership between law enforcement, LME, MCOs, NAMI, and local behavioral health provider agencies. The work of these partnerships across the state have continued this important training during the COVID pandemic, which really accelerated a lot of mental health problems. DHHS has implemented a number of behavioral health flexibilities in response to COVID-19. A number of those remain within CDHHS, reviewing each of those to determine which need to remain after the pandemic to support ongoing service delivery. LME's MCOs have announced various reimbursement rate increases for community providers as they have continued services throughout the pandemic. And part of the funding from the sale of Dorothea Dix Hospital property have been reserved to fund expansion of psychiatric beds, and Randolph was given $4 million in the budget this year to provide psychiatric beds at Randolph Health. Good Hope Hospital in Harnett County has used some of those funds and reinvestment funding from Sandhill Center to design an expansion plan for their psychiatric inpatient beds. That design will grow their bed count from 16 to 32 when complete. By North Carolina using the federal waiver for institutions of mental health, we can now use Medicaid dollars to purchase inpatient beds that were earlier not coverable under Medicaid funding. And I know that our Randolph County schools, Sandhills has contracted with them to provide a therapist for their school system, and they can do it for our city school system also. So I'm so thankful that we do have better access to behavioral health care. And now I'll turn it over to Senator Batch. Thank you.
Hi, good morning, everyone. It's really great to see you all. And actually, Haley probably didn't even know this, but she framed what I'm going to talk about just perfectly. So Haley, thank you, one, for sharing your lived experience. I think the most important part is that many of us go through life, especially with various privileges. The fact that any of us are on this call, we all have degrees, we're all working in a field, we have letters behind our names for most of us, shows that you never really understand what someone else's lived experience is behind that, right? The behind letters, behind your life, behind your experience, it's so much more valuable for everybody to hear, because it's not just that person down the street or the people that we see in our offices. And that the amazing part is that life gives us opportunities to build resilience. And you are the perfect example of what we should be striving to make sure that we are providing as many services and supports around children in particular. And so my conversation really deals right now about the mental health crisis with regards to children in our state and across the country. So I'm going to gloom and doom you a little bit for some statistics, but it'll frame the conversation about where I'm going. So in 2019, 1 in 3 high school students and half of female students reported persistent feelings of sadness, hopelessness, or overall, and that's an overall increase of 40% since 2009. And by 2018, suicide was the second leading cause of death for youth between the ages of 10 and 24. And the data suggests that 6,600 children between the ages of 10 and 24 committed suicide in 2020 alone. Meanwhile, children of color have been disproportionately impacted by mental health challenges. In recent years, suicide rates among Black children below the age of 13 have increased rapidly, with them dying at nearly twice the rate of their white peers. And COVID has simply just laid bare the already broken mental health system that currently exists and has exacerbated mental health challenges that people already had. In early 2021, emergency department visits for adolescent girls were 51% higher than the same period in 2019 and 4% higher for boys. There's been a lot of talk with regards to what the causes are with the increase. It's not just the pandemic. There's persistent bullying. Everyone says that I'm being hyperbolic when I say that social media is frankly the downfall of our civilized society, but I do believe that that is the case. We see that social media has a ridiculous and very detrimental impact to children, especially girls. We've seen an increase in eating disorders. We've seen an increase with regards to anxiety, depression, and so many other disorders that have actually ended up increasing over time. I believe that that has a large part to do with social media. There was bullying before social media, but it's a heck of a lot worse now. We see that there are academic pressures, isolation due to the pandemic. Who knew that social media couldn't cure everything? We actually need human interaction. We need touch. We need to be with one another. Also, going back to my point, social media might not be the cure-all that everybody thinks it is. And then economic stressors in families, specifically with regards to the pandemic, because we all know that when Maslow's hierarchical needs, that bottom rung is not being met and families are stressed and they can't meet their basic needs, then children are also going to be stressed. And we've also seen the increase of racism, gun violence, and alcohol and drug abuse. And so the lack of access to mental health services is also, of course, adding insult to injury with regards to all of the children that need services, and not just children, we know adults need help too. But for the context of my conversation, it's really, really important for us to look at how we can get access to every single child who needs it. We also know that socioeconomically disadvantaged children and adolescents are 2 to 3 times more likely to develop mental health challenges than those from higher socioeconomic status. But we shouldn't be surprised by this, right? I mean, we all know that the higher percentage of children from low socioeconomic status have higher ACEs scores, right? We know that that's going to be part of what we're dealing with. And so therefore we should wrap around services and provide families with assistance. And we know that includes the financial resources that are going to be limited in some families. We know that kids are going to obviously be more stressed when they live in unsafe neighborhoods, when food insecurity persists. We know that when families don't have access to medical and mental health treatment, families continue to struggle. And so we also know that the demand for mental health treatment has drastically increased. The Psychological Association survey also shows that psychologists who reported receiving more referrals in 2021 saw that number double since 2020. And so while we thought that this was going to be a pandemic, one of my clients properly coined it, in my opinion. She called it COVID, the trilogy, because we are going into yet a third year where we thought that we were going to be out of this. And while things are getting better, it doesn't mean that people are not stressed, overwhelmed, and fatigued with everything that's been going on. And we know it's had devastating effects with regards to our children and our communities. And so as a social worker and as an attorney, I've experienced a lot of those struggles with the families that I've represented over the past 16 years in practicing family law and child welfare law. I represent both parents in the child welfare system. I represent foster parents. I represent children as guardian ad litem. And what I can tell you is that it's very easy to go ahead and say, let's just focus on kids. But many times people forget kids come from family. I can tell you that in the 16 years of working in child welfare and representing parents, 85, rough estimate of mine, 85% of the mothers that I have represented have been physically, emotionally, and or sexually abused as children. They did not get treatment. They did not get services. And in turn, we expect them to then be well-functioning individuals and parents and people in our society without any treatment. And so by just treating the child is not going to solve the problem. My mom said, and I think that she's absolutely right, you change a mother, you change a family. And if we start looking and reimagining what our mental health system should look like, it should be much more family-centered and less specifically focused on a certain cohort of individuals. Most of the work that, that I do as well, and many of those children who grew up in the foster care system and who were my clients didn't get the services and treatments that they should have received during that period of time. And so it's just generational and cyclical challenges with regards to mental health and abuse. And so increasing the ability for providers to be able to be in a situation in which they can see, they can have access to see more children is really important, but they also need to get paid to do it. And I say that because in my family law practice, what I'm now seeing is a level of concierge services for mental health providers, especially in the child area. We literally I have the clients who I'm not court appointed for, who are wealthy, who can come to me and can pay, are private paying because we cannot find providers to be able to see children in particular right now. The waiting lists are ridiculously long, and many of them, because of all of the headaches that insurance has and all the red tape that they have to go through, just says they throw their hands up and say, I can get paid privately. I'm just going to go ahead and not take insurance. You can reimburse it if you want, but people cannot afford $120 or $180 per week for the needs of their children. And so it's not just we need access and let's expand Medicaid, of which we need to do and should have done a very long time ago. We also need to address the issues and challenges that face the private market and industry, in which so many private therapists are just leaving and making sure that they just go ahead and say, I just need you to pay me. That doesn't help anyone in this process. It certainly doesn't help people who are actually working for a living and living paycheck to paycheck. And so we just need to imagine and reimagine exactly what we can do with regards to mental health reform. In closing, I'll just wrap up on some of the amazing things that we've been able to do in the legislature this year. I had the good fortune of working on the passage of Michelle's Law, which will hold unregulated mental health facilities financially and criminally liable for treating people with mental health challenges. And I also was really excited to be a part of the passage of the Child Welfare Omnibus Bill, establishing a legal process now to address foster youth that languish in our EDs without proper mental health access, educational resources, and the like. And while it's not necessary to have a mental health background to be an effective legislator, when evaluating mental health legislation, it certainly helps. And so, as we, and what I would also say is that we've been very fortunate, and I grabbed a lot of stakeholders. I guess this is Haley, where you're talking about power. So I had the power with just the fact that I had senator in front of my name to be able to gather a number of stakeholders together and say, we have an absolute crisis on our hands of a mental health crisis with high acuity needs for youth. We need to get the high acuity youth and to figure out a system that's going to work better. And so I was able to bring a number of people in to go ahead and put buckets of what's legislative and what's policy so that we could try and move the ball forward instead of just spinning our wheels trying to figure out what to do. So I look forward to obviously the question and answers, but I just want to say, as a strengths-based person, I'm very solution focused, and I'm trying to figure out a way, along with all of you genius people who continue to support the families that need the most help right now, to go ahead and figure out a way to change our system and to make it much more family friendly. And I just want to say thank you all for what you do, because it is tireless work. You all need your own self-care, which we all know therapists, social workers, counselors, and the like don't do that very well. So this is my pitch to you guys. Please take self-care, because you all know that you are not worth anything if you are not showing up whole in your own lives. So thank you very much. It's great to be here with you guys today.
Thank you, Sydney and Pat. You all are such great champions, and it's just great to work with you all and to see your leadership. And Haley, thank you for your powerful comments and setting this session off with just some incredible insight. Now I'm happy to turn this over to somebody I spend every morning with, if not in person, at least on the internet. The North Carolina Health News website is something I read every morning just to see what's going on in healthcare. It is a go-to source for me. And we are delighted to have our great friend and the executive director of North Carolina Health News, Rose Hoban, here with us again this year. Rose is going to moderate the discussion of questions that were submitted and moderate this panel and the upcoming two panels. So Rose, welcome. It's good to see you in person, and I'll turn it over to you for our conversation with our panelists.
Thank you so much, Senator Woodard. It's really, it's such a pleasure to be here again. I wish we could all be in person, but let's hopefully next year. We don't have a lot of time, so I'm going to jump right in. First, I want to thank to all of our legislators who've agreed to attend and answer questions. You know, it takes courage for legislators to take questions from their constituents. So this is, it's really a great thing that all the legislators are here. I'd like to remind all of our panelists that I'm going to be keeping time. I have my phone set with a timer. And so asking you all to keep your responses to 1.5 minutes maximum, and shorter is even better. And if you want to respond to something another panelist says, if you could keep those responses to about 30 seconds. We've had a lot of questions and boiled them down. And amazingly, the very first question really addresses some of the things that all of you spoke about, which is that with the surge of mental health issues in teens and children, how can we increase those access to services and supports to meet those needs? What can be done at the legislative level? What can be done at the provider level? So I'll let folks take that question.
So I'll hop in. I think one, expand Medicaid. That would be the first thing. Two, we need to address parity within our system. If we have a co-insurance that basically ends up being $50 for a copay, it doesn't make any sense because most people can't afford to take $200 a month for their child to continue to go weekly, which we know that if you're in therapy, it's going to be at least weekly for a while, even to just build a rapport. I'd also say that we need to make sure that we find programs on the legislative level for repayment for student loans and also services where you go into underserved communities, especially in rural North Carolina, and you get loan forgiveness. I think we should start really looking at that. And I'm telling you, my time's up, so I'm going to stop talking, Valerie. Thanks.
We did in the budget provide for one psychologist for each school system. So I'm hoping and praying that we get those this year. And I know they're hard to find, probably because the need is so great. I say it's school system, at least one full-time psychologist starting in 22-23. So at the school. So we hope and pray that's going to help somewhat. And there are so many needs. But I'm glad that Sandhills is paying for one therapist themselves out of their funding. So that's good for the schools.
Mm-hmm. Haley, do you have any thoughts?
I do. And, the rise of school-based mental health programs, which some of you might be very familiar with in your county, not all counties have a school-based mental health program, but essentially allows children to see an on-site therapist during school hours. So it really reduces a lot of the common barriers to treatment, right? So transportation, parents, work schedules, and things like that can be a major barrier. That I think needs to be further expanded, in my opinion. But I also think a lot of it also needs to be done on the family system, right? Because we can give like an hour a week, but we really need parents to do the foundational work. Things like Senator Bash was talking about, limiting social media, great start.
Mm-hmm. While you all were talking, doing your presentations, people were making comments in the chat. And just as a follow-up to this question, Valerie Arendt noted that providers are leaving networks because of low reimbursement and administrative burden. And Mary Kimmel noted the need for payment models to support dyad and triad and family support. So that says to me that there could be, especially for publicly funded programs, that there could be space in there, for things like Medicaid. Do you think that there could be an appetite at the level of the legislature for making some of these improvements in reimbursement?
It's certainly, I'll try that. It certainly is possible. Anything's possible. It's just getting everybody on the same page. And I meant to mention about our mental health caucus. We did have one meeting last year. Last year I said maybe we can do that. We got 55 members, and we want to definitely try to have one. Senator Bergen, we went in as a joint caucus, and we've had one meeting, and we want to do it again. And maybe we can discuss all these things in that meeting. So I'm certainly willing to try.
Mhm.
This
And
is
we know that
Representative
and I was just going to say that we know that Medicaid, there's a lot of fraud in Medicaid, but that doesn't mean that there are a lot of bad actors. There are some. So we need to figure out how to cut the red tape and minimize the amount of laborious work that it takes for a therapist to go through the process to make sure that the services, we should be maximizing how much time you can have for clients and minimizing the amount of procedural and red tape. And so I think we can also look at that as well.
Mhm.
May I chime in?
So the next question, which was again prescient, given what you all talked about, was, access to care, rural versus urban. What can we do to make sure that rural community settings, are able to access mental health services as well as urban ones? Any thoughts?
This is Representative Cunningham. Can you hear me?
Yes, Representative Cunningham.
So there's been a couple of mobile units that have been set up to do the telehealth and to go out into the rural communities. And that's probably a good idea. But also, I wanted to go back to the question before, because Appalachian State University has a program that they come into Blowing Rock. Their masters and social worker students come into Blowing Rock and actually provide those services for free as part of their internship to gain their masters in social work. And it works in that area. And I think that's something that we're probably going to have to look at across the state and other areas that have social worker programs, counselor programs, psychologist programs, etc., because they sometimes are able to come into those facilities and even do the telehealth as well, and it works.
Mm-hmm. That's thanks for jumping in with that, Representative Cunningham. I really appreciate that. Any other thoughts on how to increase access to care in rural parts of the state?
So we need to make sure that the providers want to be and retain, like, to live in the area. So we should recruit from the areas first, especially when we're talking about kids who are going off to college. You look at the universities that are there, and I still think that loan forgiveness and putting in however much time is will then get them really committed to staying within the community. Many people want to return to the communities of which they live and serve, but they have to be able to have enough clients, patients, and we know they're there, but they have to actually be able to make a living and pay their loans off. So I think that that's one of the things that we should pilot with regards to that program to see if we can increase need.
Mm-hmm. I would just add that there's some really good comments in the chat about insurance companies and telehealth, and a lot of I agree with a lot of things that are going on in the chat.
Mm-hmm. No, the chat is really worth watching. One of the things that I think a couple people mentioned, but it really hasn't gotten a lot of it, like a deep attention this morning yet, is the opioid crisis. And anyone have some thoughts on the current status of the opioid epidemic in our state and whether the current standards of care are meeting the needs of people struggling with opioid addiction? I mean, we know right now that evidence-based best practice is medication-assisted treatment, but that's not being done in every location. Can anyone, make some comments about that?
Hey, Haley, do you want to go? I've talked about.
Sure, yeah. So the opioid epidemic has been obviously devastating. So out of the number of overdoses that we see in this country every year, over 70% are related to an opioid, and the vast majority of those are related to fentanyl that's coming over the US-Mexico land border. Fentanyl is a highly potent synthetic opioid, and literally the difference between the amount it takes to get someone high and the amount that can kill them is the few grains of sand. Now, the problem is that this isn't fentanyl that's, being made in a laboratory, like under strict FDA regulation to ensure the dosage. It's being largely made by cartel members. And so we're seeing a drastic rise in overdose because of that. It's a huge problem. And I'll let other people jump in.
I did check on some statistics for Randolph County, and for the state, we had 2,975 who died from overdoses in 2020. In the Randolph County, 2019, we had only 36, which is too many. And then we had 65 in 2020, and we had 74 last year, which is not helping. And I do know that our sheriff's office and our first responders and the emergency people are taking that shot that they give to them when they overdose to save their lives. We've got to prevent this stuff before this happens, or get them somehow to wake up, because you just can't keep giving that shot to keep bringing them back when they don't ever realize they feel like that's safe and they can do it over and over.
And Rose, the reality is we know that substance abuse treatment is expensive. Medical assisted treatment is even more expensive, but we know that that's by far the most effective with regards to making sure that we can address issues of substance use. So I'd say two things. One, we need to make sure that we're actually allowing, especially we need to increase drug treatment courts. They did an amazing job that stopped being funded. So we need to increase those to go ahead and divert people from the criminal justice system into drug treatment and actually get them services. And then we need to work with our sheriff's offices and also the Department of DPS to go ahead and actually encourage them to allow medication-assisted treatment within their facilities, because many people end up they can't take their treatment while they're actually incarcerated, which is extremely detrimental, as many of you know.
Any other follow-ups to this question? Or Haley, do you want to jump in at all?
Yeah, I would just say that I think that, the MAT has definitely become the standard of care, and that's Suboxone and Methadone. There are a lot of pros to that. We know that because of how painful and uncomfortable heroin and opiate withdrawal is, that a lot of people relapse, so it can reduce relapse. However, the problem is that when or if that person does want to come off of Suboxone or Methadone, they don't realize that the withdrawals can be 3 times stronger and longer. And really giving people informed consent, I think, is super important, so that they can know that that would happen if they would want to actually stop or taper off that medication.
Right, and having resources for people to taper adequately.
Or make a choice to, go through a withdrawal. I mean, a lot of people don't realize that opioid withdrawal, while it's very, very uncomfortable and painful, it is almost never fatal.
Right, that's true. Well, we could probably go on for an awfully long time with this Q&A. This has been a terrific panel, but I've gotten the signal that we're actually running a couple minutes over. So I'm going to hand this back off to for the next pillar and the next discussion, and which will be about effectiveness in mental health care. So I'm going to throw this back to Senator Woodard.
Thank you all so much. What an incredible panel. Rose, as you said, we could go on and on with this topic, and I know we will. So thank you to all of you for these incredible insights. Our next panel is going to be talking about effective treatment. Our presenter is Victor Armstrong, who was recently named DHHS's Chief Health Equity Officer. Victor previously served as the director of the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Abuse Services. His career has been dedicated to building and strengthening community resources to serve individuals living with mental illness. I have to say, Victor is a prodigious master of Twitter. You need to follow him if you don't. He posts frequently and offers a lot of great content. His Twitter handle is @1of2Vics. I'm going to put that in the chat so you all can follow him, because he is definitely worth following on Twitter. Our General Assembly members who are going to be joining this panel are my great friends and colleagues, Representative Donna White and Representative Carla Cunningham. So, Victor, welcome, and I'm going to turn it over to you and these great legislators.
Thank you so much, Senator Woodard, and good morning, and thank you all so much for having me and inviting me to spend some time with you today. And in sharing this morning, I want to speak to you in part as a policymaker, but also as a person of color and a member of a historically marginalized population. I am Deputy Secretary for Health Equity and Chief Health Equity Officer for DHHS and former Director of the Division of Mental Health. I'm also an arrogantly proud social worker. I'm a husband and a father to 3 Black boys. I'm a mental health advocate. I'm the son of a preacher born and raised on dirt roads in Plymouth, North Carolina, spending summers working in tobacco fields, though I now reside in Charlotte. I was raised by two loving parents, one a preacher and the other a school secretary. Neither of my parents went to college, but they raised 5 children, all of whom graduated from HBCUs. And I share all of this because I'm the sum of all of these things. And when you look at me, you no doubt have a perception of who I am based on my story, based on the situation of our encounter and our interaction, but also based on your own lived experience. You decide about how you will interact with me. We decide about how we'll interact with one another, dictated in part by the situation, but also based on our own individual perceptions, those things that we have learned, been taught, or been socialized to see, and the resources available to us. Much as we today will interact as tradition and formality dictate, in many ways our behavioral health system has worked the same way. We have addressed mental health in a traditional manner with traditional funding streams, traditional provider-patient relationships, with our traditional treatment modalities, with our traditional, often paternalistic biases. Historically, whether it is due to arrogance or apathy, we in the mental health profession have not practiced through a lens of equity, and our services have not been funded through a lens of equity. We have instead operated through the lens of perception, and perception can easily devolve into bias, disparity, and structural exclusion. You see, when we talk about applying the lens of equity to mental health, which is essential to effective mental health, we're not just speaking of equity as it pertains to race and culture and ethnicity. The lens of equity is about the intersectionality of race, culture, ethnicity, geography, socioeconomic status, all of those things, in addition to living with mental health challenges. It's about being Black and living with a serious mental illness. It's about being Latino and living with intellectual disabilities or traumatic brain injury. It's about being an American Indian and living with a substance use disorder. It's about being a trans Asian person struggling with an anxiety disorder exacerbated by the discrimination that often accompanies mental illness, the hatred that's perpetuated toward trans Americans, and the increasing rates of violence against Asian Americans. It is my contention that the very construct of our mental health system has historically been flawed, beginning with our response to individuals experiencing mental health emergencies. Our current system was not built from the perspective of individuals with lived behavioral health experience, nor was it designed to address their mental health needs. I would argue that it has historically been designed not to protect and nurture the individual experiencing the mental health emergency, or the crisis as we call it, but to protect the rest of us from the individual experiencing the mental health emergency, and that is wrong. Equity, and health equity in particular, at its core, is about ensuring that every individual has a fair and just opportunity to achieve their best health outcome, to live their healthiest life. And how we apply the lens of what is fair and just has historically depended on the perception of policymakers, policy regulators, and service providers. It has not historically taken into account the perception and lived experience of those whom we are charged with serving. And unless you have my voice at the table, you don't know my perspective, and you can't substitute for or recreate my voice. If you haven't walked in my shoes, you don't have my lens. But when I walk into your office or agency, I bring all of my lived experience and my perception of how you value my lived experience with me. Without acknowledging the value of lived experience, we can't effectively acknowledge the bias, both implicit and explicit, that is built into our system or its impact on our interaction with those that we serve. I submit that implicit bias, though it is outside of an individual clinician, service providers, or policymakers' conscious awareness, it is woven into the fabric of behavioral health. I would further submit that it even influences a provider's ability to engage in truly patient-centered care. How can you engage in person-centered, patient-centered care with me if you don't acknowledge, understand, or accept my perception of my life as a Black man in America? And behavioral health is particularly vulnerable to implicit bias because the diagnosis and treatment of mental health conditions rely so heavily on provider discretion and the provider's unconscious attitudes, or even the policymakers' unconscious attitudes toward historically marginalized populations can have a direct impact on outcomes for individuals seeking treatment. And make no mistake about it, individuals living with mental health challenges, with traumatic brain injury, with addictions, with physical disabilities are and have always been historically marginalized. Why does all this matter? It matters because it impacts access. It impacts how people enter the mental health system. For example, research indicates that Black adults are 20% more likely to report psychological stressors than our white counterparts, but we are less likely to enter treatment and more likely to terminate treatment prematurely, and more likely to use emergency departments to access mental health services. People of color often don't have access to outpatient services or crisis services within their communities. And if you must take 3 buses to get to your appointment, or you don't have transportation to get to that appointment, you are less likely to make and keep an initial appointment and less likely to make a follow-up appointment. This makes it more likely that people of color are introduced to the behavioral health system when they are in a state of crisis. Such being the case, many people of color enter the behavioral health system via the back of a police car or an acute care emergency department, neither of which is conducive to good clinical outcomes, and neither of which is likely to foster a positive relationship with the mental health system. Historically, our interventions have lacked cultural competence. Interventions and responses should be person-centered and reflect the strengths and resilience of those we serve. Suicide prevention, for example, should be about more than detaining someone when they are in crisis. Yes, crisis intervention is about preventing a person from attempting to harm themselves or others. And yes, mental health legislation allows people expressing suicidal thoughts to be involuntarily committed. But assessing risk at the individual level or the community level involves considering not only risk factors, but also protective factors. If you don't understand or acknowledge the impact of cultural beliefs, including stigma and relationships with law enforcement, or the impact of structural racism on my life and my perception of my place in America, your intervention can do more harm than good. That intervention, in fact, may become another traumatic experience that I have to carry. Secretary Kinsley spoke about many of our interventions currently underway. We can and will address many of the issues of access by supporting the creation of more mental health resources in communities of color and underserved zip codes, by creating more community-based resources that provide access to upstream treatment rather than continuing in the crisis response mode that we have existed in for the past several decades, by engaging in one of the Secretary's 3 priorities of building a strong and diverse workforce that mirrors the populations served. I offer one solution for consideration. We have a ready-made but underutilized workforce of individuals with lived behavioral health experience. Black, white, Latino, Asian, and Native American. In North Carolina, we have roughly 4,000 trained certified peer specialists with only about 1,600 gainfully employed. We need to utilize the peer workforce and pay them a living wage. We need to partner with historically Black colleges and universities and minority serving institutions to build a multicultural workforce. We need to partner with clinicians of color and fund studies that consider the nuances of race, culture, and ethnicity and the impact on mental wellness. And yes, we need to better understand the impact of systemic racism and complex trauma experienced by people of color. We are working to build and earn trust between historically marginalized communities, behavioral health providers, and funders. We are working with community partners, community media, and grassroots messaging to educate communities and combat stigma and address concerns about receiving mental health treatment. By giving voice to those with lived experience, we can and will reimagine our approach to behavioral health. Without the intersectionality of clinical expertise and the voice of historically marginalized communities, including those with living with mental health challenges, addiction, IDD, and TBI that have been historically marginalized, without that voice, our approach will be ill-advised, ill-informed, and ill-fated. Without that voice, we will, as we have in the past, speak to the opinions of intellectuals, the desires of legislators, and the needs of the majority, potentially creating a system that may work for 80% of the aggregate population in need, but potentially not address 80% of the Black population, of the Latinx population, or the Native American population. And it will not effectively speak to the needs of those living with mental health challenges, physical disabilities, traumatic brain injury, or those recovering from the trauma of adverse childhood experiences. In conclusion, I believe that as devastating as COVID-19 has been, it has been in many ways an opportunity for a reset in how we embed equity into behavioral health and how we build the workforce that looks like the communities that we serve, but it will take intentionality and commitment. You see, the long-standing disparities that were illuminated by COVID-19 did not only pertain to disparities in physical health and healthcare, but behavioral health as well. And due to these long-standing health disparities, much work remains in embedding health equity into the fabric of behavioral health and behavioral health care delivery. And this will require continued effort to earn trust from historically marginalized communities and to incorporate the multifaceted voices of lived experience into mitigation strategies. It will require a strategy of partnering with historically marginalized communities to not only share accurate information about treatment and access, but listening to people's concerns, accepting the fact that we have missed the mark of equity for far too long, and by answering their questions with transparency. We also have to be intentional about not only training providers in cultural competence and cultural humility, but in reviewing our treatment models and seeking to make sure that our treatment takes into account the realities of historical trauma and structural exclusion. These are all a part of the intersectionality of our lived experience. We will need public-private partnerships with community-based organizations and coalitions to increase access to care, reduce stigma, and increase outcomes among BIPOC populations. Community collaboration affords us the opportunity to provide not only an evidence-informed response to the needs of those we serve, but also a community-informed response that takes into account the nuances of disability, race, ethnicity, culture, language, geography, and socioeconomic status. These are all social drivers that impact an individual's ability to navigate their healthcare journey. And finally, our approach must be data-driven. Prioritizing equity data requires that we focus on quantifying the disparity while recognizing and acknowledging long-standing inequities. A successful data strategy will identify the underlying social inequities and resources needed to afford all patients, consumers, guests, constituents a fair and just opportunity to achieve their healthiest outcome. Our evaluation efforts cannot be limited to measuring average impact on the health of the whole population. Instead, we will need to measure change in outcomes among selected disadvantaged groups, quantify the size of gaps between disadvantaged and advantaged groups, seek to engage disproportionately impacted communities in solution generation, and to measure if efforts have been successful. Historically, not all communities have equally benefited from the advancements in science and thought leadership. And trust me, I know from my life experience that if we don't build equity into our programs and practices on the front end, if we don't recognize the fierce urgency of now, the most powerless and vulnerable among us will not receive equity or justice. And justice, after all, is not a black or white issue. It is about humanity and the inherent worth of all human beings. Thank you. And I believe I'm now turning this over to Representative White.
Thank you, Mr. Armstrong. I just wanted to give a shout out to Representative Insko. She has been a mentor for me as I've been in the General Assembly. She held a couple of the positions that I currently hold now, Health and Human Services Appropriations and Health Policy. And she has just been a silent mentor and a vocal mentor, and I really appreciate her. And thank you so much for giving her that honor today. She has certainly earned it. I wanted to just say hello to my good friend, Senator Woodard, and thank you. You're doing a great job. I also want to thank the legislative team for putting this together, this planning team. It was just amazing, all the detail that they've gone to make this session run smoothly. So I also want to just give a big shout out to Secretary Kinsley. I am so thankful for you and for your position that you're currently in. I appreciate your vision and your collaboration, and I appreciate all the work that we've already started talking about and interacting with. And I just know that you're in the right place at the right time, doing the right thing. So thank you so much for that. Obviously, as Secretary Kinsley mentioned and other speakers today have mentioned, this problem has existed for a long time, but COVID certainly put that spotlight on it. 40% of adults reported symptoms of mental health issues during COVID and still are reporting. There was a 39% of increase in retail sales of alcohol. I guess being able to get it by drive-through increased those sales. A 24% increase in pediatric ED visits for mental health in children's ages 5 to 11, and 31% increases for those 12 to 17. More than half of the individuals who lost employment or financial stability reported anxiety and depression, and 10,000 of them sent me emails about that, and I answered all of them. It took me 2.5 weeks, but so we'll move on. Those are some of the stats I just wanted to share with you. My story. I'm a public health nurse, and I worked in Orange County first, and when it was a 5-county health department. I then went back home to Johnston County, where I currently live and represent this constituents of this fastest growing district in the state. I worked when I was in Johnston County, I was a pediatric nurse manager for the health department, and also ran a well child, sick child clinic. I was one of the first nurse extenders that then led into the nurse practitioner program. The nurse practitioners program was already being developed, but this was like an intermediary fix. But running that well child clinic and mostly running the sick child clinic on a regular basis, not as intense as it is now, but on a regular basis, we would have a client that would come in with their child, and the parent needed more help at that moment than the child. The good thing is that we had a local mental health center that was just across the street, and it was attached to the hospital. And I'm sharing with you now what I think is the most effective model of mental health care. When you are in your community, when you can go into a provider and they know that there's a resource very close by that they can send you to for immediate assessment and treatment as needed, and then long-term treatment as needed. If you have the need to be hospitalized, that you can, for a few days, you can go into a facility in your community next door to the mental health center where you received your assessment and immediate treatment. I know that is pie in the sky, but I think that if we're going to really be effective, and we're going to change the numbers that we've heard about today and that we continue to talk about, I know that we've got to do something drastic. And Secretary Kinsley and I had a chance to talk before he became secretary, and I know that he has some similar visions in some areas, and that I do. But I just know that local. For the last few months, I've been talking to public health professionals, mental health professionals. I have been talking to direct caregivers. I've been talking to administrators in hospitals. And they too, many of them remember the day when mental health was really local in all aspects. And I just believe that that's where we need to put our resources, and that's where we need to focus, is to really try to get that service back to the local community. So we in the General Assembly over the last 5 or 6 years, I've been there 5, but one of these dates will date me back to my involvement with in 2013. In 2019, because of the increase in school violence, which of course we all know now is related to most specifically to mental health issues in children and in their families, the Speaker established a House Select Committee, the School Health Committee, and we had we traveled across the state, and we heard from all the types of professionals that we've mentioned here today. And as an outcome of that, we increased funding for psychologists, school counselors, and school nurses. We put a mandatory training for SRO officers and for teachers and for staff, so that they would have exposure to some mental health background. We also increased the safety of the parameters around the school and so forth. We put a lot of money into that initiative and aligned ourselves with the Columbine model, and it's very successful. And through the Safer Schools Task Force that was initiated in 2013, and I was the first and only school board member on that committee for 3 or 4 years. And then when Governor Cooper came in, he continued that model, and it is just going to great strides addressing mental health issues in the school and other issues as well. But he also kept me on the Safer Schools Task Force, and I will be forever grateful for that. So if you're listening, Governor Cooper, thank you. Some of the things that has come out of the Safer Schools Task Force and that initial House Select Committee, we in school mental health, for school mental health professionals, we know what the ratio is now, and we know that it's not good. So I'm going to have to get a little closer to my notes here. We need to invest significantly in to improve those ratios for school psychologists, school social workers, and counselors in K-12. We do know that partnershiping with telehealth issues, with telehealth partnerships and workforce programs that incentivize careers in mental health would be a way to keep that pipeline open for new people coming in. We do know that we need to address the issue of school nurse wages, because they have to enter at the first year teacher pay, but they can't be a first year nurse. They have to be someone with experience and lots of experience to be the only nurse maybe covering several schools. The school family community partnerships, we currently know that we have those engagements, but now the state statutes and policies say encourage but do not require. And we think that it should say encourage school districts to adopt a family engagement, or maybe require a school, not encourage, but require a school to adopt a family engagement plan. So I think that would be one of the most significant things we can do at this time, in addition to what we're already doing. In teacher and safe training, we have a current session law that requires each K-12 school to adopt a school mental health plan that includes training of school personnel in youth mental health, suicide prevention, substance abuse and substance abuse prevention, sex trafficking prevention, and teenage dating violence. That is already in session law, but when I talk to local school officials, they say, when are we going to do all this? This is left up a lot of times to the teachers because we don't have enough professionals, mental health professionals in the school. We also, I think we should require a well-being check for students and for staff on an annual basis in K-12. So in the Child Wellbeing Transformation Council, we have certainly done a lot. We met for 1.5 years, and a lot that's in the Now Family First Act and other initiatives that are state are being promoted by DHHS came out of the recommendations sent to them from the Child Wellbeing Transformation Council. So it was an honor to be able to serve at that capacity. And I think that was one of the most effective things that we've done in a long time, because we brought caregivers from across the state, social workers, foster parents, we brought foster care parents, we brought guardian ad litems, we brought judges, we covered the gamut, and that has led to us going into our Departments of Social Services and enhancing, and we have the Department of Health and Human Services is really doing a tremendous job in looking at remodeling how we support and bring the DSS more local and with more state support. So I appreciate that. Secretary Kinsley mentioned the emergency room boarding session law 2021-180/180, and it is the intent of the General Assembly to provide funding to hospitals for behavioral health services provided to Medicaid beneficiaries while those beneficiaries await discharge to a more appropriate setting, so that they will be getting the appropriate care even though they may still be in the hospital. We hope that they will, we have increased hospital beds this year with our state funding, and we hope that that will help our local hospitals so that they are not having to keep mental health patients, especially youth, in the hallways in the emergency room. But my shout out to the hospitals. They're doing as good a job as they can do with the resources that they currently have. The Child Fatality Task Force has been another big advocate for reducing and addressing the mental health and behavioral health issues. I've been proud to serve on that since I came to the General Assembly in 2017. We have spent a good deal. We had a bill this year for safe surrender to help young adults who are have delivered a baby and don't know what to do with the baby. House Bill 130 is still an active bill, and I would really give a shout out to the Senate if they would help me get that through. We are very concerned about the suicide rates that have just spiraled in children 10 to 14. Suicide is the #1 cause of death in North Carolina for children 10 to 14. The #3 death, the reason for death is homicides in that same age group. In the age group of 15 to 17, over homicide is the #1 cause of death, and suicide is the #3 cause of death. So it just reverses for the two age groups, but it's bad, however it's listed 1, 2, or 3, it is still a very serious situation. The other thing that we're very concerned about is that we've got to prevent youth initiating substance abuse. And that begins with vaping in the schools. That begins with temporary with marijuana. And I know that there's bills out there now, and I know that there are folks that don't want me to say that today, but I'm telling you, if it's available to adults, the youth will get it because they have more access and they have much more knowledge about some of the things that we've been talking about today than we do. So I just think that we really need to address raising the legal age for substance to 21 and to make sure that we don't continue to perpetuate by introducing new substances or substances that have not been legal before into that legal capacity. So I appreciate your help. I don't know if I've got time left, so if the moderator will let me know how many seconds I've got left. My time is up. Okay. Well, let me just say that I'll take 2 seconds. We in the budget right now, $104 million was put out to increase local mental health services throughout the state in this current budget, and it was passed. We're so thankful for that. In addition to expanding the coverage for women who have children and they're in the foster care program, we're not cutting them off from Medicaid right now. So thank you so much. I appreciate your attention. And we'll excuse me, and I'm supposed to say, Representative Cunningham, the floor is yours.
Thank you so much, Rose. And Representative Inscoe, I am so happy for you, but I hate to see you go. I have really learned so much from you since I've been in the General Assembly. As you all probably know, moving on, I would say that opportunity knocks. And the reason I say opportunity knocks is because, yes, the pandemic presented itself, but in that pandemic, it also presented and unveiled the issue of healthcare disparities in the state of North Carolina. Healthcare disparities have been historical in people of color, African American, Latino, American Indians. It's been historical in underserved communities. Those underserved communities are rural areas. And I am a rural birth born girl out of Anson County. So I know what it is to live on land, farm the land, go get your chicken eggs, kill the pig, fix it all up, slaughter, and prepare your food from that and hang it out in the smokehouse. Yes, high fat content. Yes, not the best thing for us to be eating. But guess what? Those options were limited. Those options were limited. We have seen the evidence of this during COVID-19 pandemic, noting that more African Americans died from COVID-19 than Caucasians. The Department of Health and Human Services, under the direction of Secretary Mandy Cohen and Deputy Secretary Cody Kinsley, worked with us, Senator Gladys Robinson, myself, in touching communities of color, as well as Latinos and other underserved communities, to look at not just by race, but the demographics, where these people are, who were getting their vaccines, and what was available to them in their Pacific area so that they could get the health vaccinations, and things that they needed to remain safe in our communities. But just as COVID showed us, it also unveiled the view of where we are in mental health, the stigma attached to it in our communities, the culture that's attached to it in our communities. So we were able to work with African American churches, all churches. We didn't limit where we went or what doors we knocked on, so that people would have accessibility to get their vaccines or whatever. So that happened, but it just didn't happen on its own, because originally the data that was put out, it wasn't telling us where these people were. It wasn't telling us their ethnicity. It wasn't telling us their race. It wasn't telling us significant data that we needed to take into consideration in how we distribute into the communities of color, where healthcare disparities have been historical and they're not just going to disappear. So that happened. Fewer African Americans seek mental health services due to a long history of cultural views and the stigma attached to it, to mental health services. Fewer African Americans seek substance use services as well due to costs and availabilities of services. Carrying the burden, a large portion of caregiving falls back largely to African American women in our communities. We are expected to be strong and resilient no matter what the circumstance or the journey we walk, or what life presents to us. And I say it because I am one of those people. It is a challenge to even know who do I call to get services. Where do I begin? Our lives are packed with a multiplicity of issues of a to-do list: education, food, housing, safety, etc. Just as we focus on education literacy, financial literacy, we possibly need to change our language and how we talk about healthcare services. We've been saying healthcare advocacy, but it hasn't changed. The results, the outcomes have not changed. Yes, you can advocate, but we need to know before we get to advocacy. And possibly we need to start early with healthcare literacy in schools. You take a healthcare course, they push education literacy, they push financial literacy. Maybe we need a healthcare literacy course, because that would begin to start those conversations early with children while their minds are receptive and they can move on into adulthood doing great advocacy, not for someone else, but for themselves. Consumers and families do not know what information is even available to them. There's also a need to restore trust in our communities, in the healthcare communities. So we have a lot of things that are going on, but mental health crisis was already here. It's just exacerbated. So there is more for us to do, but with what is coming forth, there's more opportunity, and the opportunity knocks for us now, not to take away anything from the physical aspect, not to take anything from education. But what I say, if you can't breathe, you can't read. If you can't breathe, you can't read. And so we have children right now that are going to be experiencing the trauma of the COVID, as well as adults. We're experiencing it too. We may not want to acknowledge it, but some of us have anxiety. I still have a little bit when I show up and people not doing what they're supposed to be doing. Yeah, so if I'm doing it, then the average person is doing it. We're not so much different than what we think we are. Thank you, and I'll conclude there.
Wow, what an amazing set of speakers. This has been an amazing, this has been an absolutely amazing set of speakers. Thank you so much for both our first set of speakers and just now Victor and Representatives White and Representative Cunningham. You know, I'm reminded of that old quote, about how in the Chinese language, the character for crisis is a combination of the characters for danger and opportunity. And I'm really glad all of you talked about those opportunities that exist. And that kind of fits really well into, given how the pandemic and the past 2 years have laid bare so much of what's lacking in the system, it fits really well into the first question that we had pre-prepared, which is that, I think one of the things that was remarkable in the past couple of years was the way that people came together across the aisle to address what was happening in the pandemic. Especially in North Carolina, I think we really were a model of how legislators came together across the aisle. And, what can be done on a bipartisan level to collaborate to increase general health and behavioral health access and well-being of North Carolinians? Yeah, does anyone want to?
I'd love to be the first one to take that question. We've been doing it. When COVID hit, we started doing it. And the speaker did the CARES Act committee. It was bipartisan. But we still, no matter who is on the other side of the aisle, continue to have those conversations. They don't know your walk of life. You don't know their walk of life. So if you can communicate and continue those conversations, you will really learn who those people are, and they will have the opportunity to learn who you are. And that's how you build that relationship to work together. And it works. I mean, it's not always comfortable, but that's what you must do, is step out of boundaries that you're comfortable in.
Mm-hmm. Mm-hmm. Anyone else have thoughts?
Since I've been in the legislature, and I guess I'm the freshman on this panel today, since I've just been there since 17. But being a public health nurse my whole life, I just always knew that collaboration was the way to help my patients. I couldn't, when I worked in Hillsborough in the Orange County Health Department, I was basically working with the same socioeconomic level of patients that I would work with when I came to Johnston County. But there was a vast difference when I was using the same model of teaching, the same model of coaching and all that. I just couldn't get through to my Johnston County clients for a few weeks. And I went to my astute health director and I said, I think I've got to rewrite all of my all my training and all my guidance, because my constituents are just, my patients are just not getting this. I don't understand. And then she and I talked, and she said, you were working in Hillsborough, and you were very close to a university campus where, by osmosis, people that live closer to education and closer to different amenities that maybe they don't personally have themselves, they do glean from that. And so that was a really life lesson for me, is that it's very important. And because in Johnston County, our county was about 40,000 people at that time. It's now over 200,000, but it was about 40,000 people, very rural. And so what I did, instead of going in with my little platform speech, I said, I started working with them. Tell me where you are. Tell me what you're hearing me say and what you're not hearing me say, and that developed a whole new rapport. And so I just feel like that. And what I've done since I've been in the General Assembly is remembered that, is to walk across the aisle, to talk with people, to invite them to be on my bills, to get on their bills. I think that is very important, is that we have co-ed sponsorship, co-partisanship sponsorship of our bills. It makes it go much easier, and they usually get passed. So I just think that collaboration, cooperation is very, very important, and relationship building is number one.
Mm-hmm. Victor, do you have any thoughts?
Yeah, I would just say, from my perspective, finding commonality starts with recognizing the common denominator. And I think that whether we're talking about Black men or people in general who live with mental health challenges, we recognize the life expectancy of Black men is about 15 years less than the general population. For people living with serious mental illness, it's 10 to 25 years. So you're in that same range. And I think when we look at the comorbidities and the things that we need to address, it's about getting upstream. The common denominator is not just the diet of high salt and fat content. It's also the constant diet of bias, discrimination, and trauma that it's a common denominator. And I think though, if we recognize the root of trauma and the root of structural exclusion, I think that's a place to start, because I think we can all find a common ground in there, whether you're a person of color, whether you're from a rural community, or whatever your background is.
Mm-hmm. Folks, we are running late. So I've been negotiating with the organizers to give us a couple more minutes on this panel. So what we're going to do is we're going to give you only 30 seconds to answer initially your questions. We're going to do one more question and then move on. And one of the questions that had come in from the folks who signed up was, how can DHHS work with the General Assembly to ensure that the most vulnerable populations are being empowered and not oppressed? What can you do at the legislative session, at the legislative level? What can you and DHHS do together to help raise up the folks who are the most vulnerable?
I'd like to start with that if I could.
I'd like to take it.
Well, why don't you start, Representative White, and then because you started on the first one, Representative Cunningham. So.
Okay, thank you. Well, first of all, I think that please let me know when I'm at 28 seconds. First of all, I think I'm very excited for our new leadership. I think Secretary Kinsley is a very good listener and a collaborator, and he's also very pragmatic. And I think that working together with his leadership, and we've already started having small group meetings with leadership, with the committees of health chairs and so forth. So I think when we can work out issues before they become issues, when we cannot have to reprimand, when we can just support, I think that is one of the most important things for us to do.
Mm-hmm. Representative Cunningham.
Thank you. I think we work closely with the Department of Health and Human Services. What I would just say is they need to continue to educate us. We're doing legislation. We don't know. We give the Department of Health and Human Services a large amount of discretion to do things with what we fund them with. And we don't know all that they're doing over there until we start looking, because I didn't even know that it was an assessment tool up on the Department of Health and Human Services that look at healthcare outcomes until I started looking. I didn't know it was there. How many of the other ones noticed it's there? Probably a whole lot of us. So I think, they need to keep educating us, and we still keep conversation ongoing.
Mm-hmm. Victor, that seems that they're throwing the ball in your court somewhat.
Yeah, and I think rightfully so. I think at DHHS we have the ability to convene people, and I strongly believe in convening people at the ground level, at the community level, having the voices of lived experience at the table, and then we can provide legislators a template. This is what we believe will work if you will fund us to do this. And so I think we're doing more of that now, having that approach, particularly with Secretary Kinsley, very clearly outlining his top priorities, and doing all of this with the lens toward health equity. So I think we're heading down that path. Not that we haven't in the past, but I think that we're doing it more so now than ever. Thank you.
I would love to see this panel just go on and on, because it's been really interesting. But I'm going to throw it back to Senator Woodard to introduce the third panel, which is discussing lifelong supports in mental health. So thanks to all these panelists.
Great job, all of you. Thank you. Incredible ideas, incredible thoughts, and a lot more conversation to come. That's what makes these breakfasts so great, is that we try to fit 12 pounds in a 10-pound bag. Let's move on to panel 3. Where we're going to talk about lifelong supports. Our presenter is Tava Mahadevan, who's Director of Operations for at the UNC Center of Excellence in Community Mental Health. He does a lot of stuff over at UNC, includes serving on the clinical faculty in the Department of Psychiatry. He also founded several programs to serve individuals with mental illness and other disabilities, including UNC PAWS. This is a program that trains rescue dogs to serve as support dogs for people with disabilities. Joining Mr. Mahadevan are our two legislators, Representative Wayne Sasser, and our Lifetime Achievement recipient today, Representative Verla Insko. Please join me in welcoming Mr. Mahadevan.
Thank you so much, Senator Woodard. Can you hear me okay?
Yeah, we got you. You sound great.
Great. And I've got some slides here. I don't know if you can see them too.
Yes, we got them.
Great. I'm going to keep mine, I know for the sake of time, really short and quickly go through some of these slides. Probably start with right here. I know we had talked and learned, and for the last several years, about social determinants of health. I just want you to look at this slide here. There's so much research work that has been done, and we know just looking at this, over 80% of somebody's health outcomes are not based on our traditional care. We know this. Anecdotally, we've known this. We know how much jobs are important. We know how much income is important. Where people live is important. And if you look at this person here, the legs below the knees, less than 20% is, that's our traditional healthcare. It's amazing how much resources we put into that 20% and how much minimum resources goes into the other 80%. This is an important piece. And I know we know about this, but it is time for us to do something about it and kind of flip this where we are using more resources into that 80% to help someone so we can prevent some of the things that we are experiencing with our vulnerable groups of people and not kind of on the other end provide crisis services. The thing that I want to focus today just quickly is supportive housing. Housing is paramount for people with serious mental illness. As we know, housing helps people live a stable life. We know how housing reduces all the costly systems. We know housing can be unbelievably helpful in terms of improving people's health. This is a slide from about 10 years ago. It's from TAC, Technical Assistance Center, with people living with supplemental security income. Used to be about $750 a month. And at that time, just for a bedroom was about $780. That's over 100% of somebody's income. This is 2021, last year. Supplemental income went up by a little bit, $794. Housing costs have gone up to $1,063 an average income for one bedroom apartment. Way more, 128% of their income. This I pulled out from last week. Average rent in the Raleigh area right now is over $1,450. Chapel Hill, Durham area is about $1,350. Rent is going up unbelievably high. And if this is again from 2 days ago, I pulled out, rent.com came up with average rent for one bedroom home in North Carolina right now is $1,378, $1,378. And SSI is $841, over $500 that's needed if somebody doesn't have Section 8 or some sort of a housing voucher, which not too many people have them. That's where our story begins in. We embarked on a very ambitious project looking at how we can provide safe and affordable housing for someone who doesn't have any of these extra Section 8 funding or other funding coming in. There are creative ways of doing things, and we were able to bring in the university resources, bring in churches, bring in county governments, create the public-private partnership, and came up with the tiny homes model. How do we do tiny homes as a new way of looking at affordable housing for people living with serious mental illness? It's not talking about it. We were able to work with the county government, and the goal is to be a roadmap here, not just to do in one county. We want to do this in every county in North Carolina. We were able to work through the details, build the first pilot home. It's about 326 square feet. As you see, here are some pictures you may be able to see. It's a beautiful home. And we work with UNC School of Social Work as a huge partner, bringing the research opportunity from UNC. And this is what we heard from people who lived in that house, gave us feedback. Tiny homes are huge for people with serious mental illness. And the goal is to be able to build a rich, resource-rich community And we want to be able to do this for $50,000. I know there are supply chain issues now, costs have gone up, but we can do this in every community and keep the rent for those folks at a third, especially someone living on SSI at $250 a month, so they have extra funds that they can use them. We have worked through all the zoning issues, planning department issues, water, sewer, all those infrastructures, and we have a master plan developed, have all the entitlements approved. And it's also in a community, it's at the farm at Penny Lane that has several other services, including many, many non-medical interventions. We have yoga, pottery, music, things that people need to live a life beyond medications and traditional therapy. It can be done in rural communities. It can be done in urban communities. Here are some designs. The construction phase has begun. I wanted to show you this picture because this shows a true partnership. We have university deans who are involved. We have architects involved. We have small nonprofits involved. We have county commissioners that have come together. We have students coming together, and we have people receiving services coming together, forming that partnerships, working with faith-based groups. This can be done. Our clearing has already begun, and the site is set and ready. Here is a living example of a partnership working with NC State School of Design. I know Rep. Cunningham talked about Appalachian State. UNC alone has 16 campuses across North Carolina. Every campus should be partnering all the way from the western part of the state to the eastern part of the state. This was the pavilion designed and built just 3 months ago at the farm at Penny Lane, especially with COVID, for folks to be able to be outside, be part of groups, be part of cooking classes, learn skills, be part of the community, so that it doesn't have to be always the traditional systems that has to come and help. We need to bring in people outside of our system, law schools. We need to bring in churches. We need to bring pretty much everyone outside of who we are currently working with right now. Here is an architect rendering of the homes that are going to be built. Homes were getting harder to build. As you know, the building industry is completely blown up right now. It is hard to find builders, but we are going to be working with our very first home is going to be built by Hope Renovations. It's a small nonprofit that's partnering to work with the farm at Penny Lane, all run by women. They hire people coming out of incarceration or coming out of domestic violence kinds of situations, train them, be able to be builders, because it's hard to find builders, but we have resources that we can do from within. And a big shout out to UNC School of Social Work for being such a wonderful partner in working with us. So I would like to end my presentation here, and I love this quote: you can solve a problem on the same level that we created it. We have to rise above it to the next level, by Albert Einstein. And I would like to invite at this point Representative Insko to take the mic.
Oh, thank you. And Tava, that was really very helpful information. I've really enjoyed everything I've heard this morning. We've got a wealth of information here and a lot of questions. I'm gonna start with the end. I would recommend that you all create some study committees. Over the years, we've had various study committees to look at things like lifelong supports and other ideas that are in the chat. The chat has just a lot of really good ideas, and to organize how to do that and then how to fund it. So we've had some cuts to behavioral health over the years, and the needs continue to grow. We still don't have lifelong. We don't have lifelong supports for any group, and really even for low grade, more minor mental health issues, people really do need lifelong supports, how to care for themselves and how to get care throughout the whole lifespan. I think that it doesn't just involve mental health services, I mean, direct mental health care. It also involves things like good education, good transportation, good social networks, And so, I mean, lifelong care is really a fully a place to live. So it really involves more than just a lifelong support for mental health services. It's much broader than that. So we do have home and community-based services under the Medicaid programs, but they have a really long wait list and they're not comprehensive in scope. So the Medicaid program, the innovations waiver we have that is supported living for those who need it. But that also doesn't cover all the people that need that kind of support. So our goal, of course, is to have people be able to live for any typical person. We want people with mental health to be integrated into the everyday community. We all have mental health problems. And so we also have a broad array. So even people with more severe and persistent mental illness, we want them to live in the community as well as much as they can. We do not want people in institutional care. And I think that's been one of the goals for our work over the last 20 years, is to reduce the number of people that actually get sent to institutions. And we are now having more and more involuntary commitments. And so I think a lot of that has to do with whether or not we have enough money in the system. I think that I hope you will take a really good, close look at the services that we need and how much money that's going to take to provide the kind of care that gives us a payback. If you provide a low level of care, you just actually it's more expensive than if you provide a high quality care and keep people out of institutions and keep them integrated into the regular lifelong community of where we all want people to belong. We do have some community-based supports like clubhouses. I think that's another thing to look at for lifelong supports, is what can the system do? What can we get through Medicaid coverage or state dollars that need to be put in? How could we engage nonprofit organizations to provide part of that lifelong care? The whole array. So I really do think that that it may be time for one of those study groups where we look at what's available, what's needed, and how we can begin to fill in the gaps. I think I didn't have especially 7 minutes of comments, but I think that covers most of what I wanted to say, and so I'll give you all some time back. And I think that see who else is Representative Sasser. So and good to be here.
Thank you, ma'am. Just like to say, am I on? Yeah, I'm here now. What a pleasure it's been to just be here this morning. I appreciate the invitation. I want to thank Representative Ensko for all her willingness to work across the aisle. So easy to work with, and we like to sit around and tell each other and all of us our story, because we've all got a story. I didn't realize that, Representative Cunningham's one of my best friends, but I didn't realize that she had killed hogs on the farm and had gardens and all the same stuff the way I grew up. But anyway, I'll get focused here a little bit. It has been a privilege to be here this morning, especially with all these experts and the legislators who are dedicated to developing policies that will improve the quality of life for the people with mental illness. As we've sat here for the last 2.5 hours, we've heard about a lot of the past in mental health, and a lot of it's not been pretty. We've heard about the present in mental health, and it's not been pretty mostly because of COVID and all the isolation that's been caused by that. But we're going to pray that the future is going to be better. And that's the reason we're here this morning. That's the reason that us legislators are trying to get educated and figure out what we need to do and how we need to do a better job, and try to continue all the hard work that Representative Insko has done in the past. As a pharmacist for the last 47 years, most of my exposure to people with mental health has been in the medication side. So we have some really good medications that will treat people with mental illness today. The problem has been with connecting the patient with the prescriber to get the diagnosis, then the medication prescribed in the patient's system where the medication can work. Now, I'm not naive enough to think that solves all the problem, but I'm also practical enough to understand that it is a monster undertaking. This year we passed House Bill 96 in the legislature that allowed pharmacists to administer injectables. Now, of course, everybody's aware that pharmacists have given hundreds of thousands of vaccines over the last few years, but now we're going to be able to make it easier for mental health patients to come in the pharmacy and get their long-acting injectables. And this is just one of the small improvements that we can do to help solve the problems that mental health people have with access to care. The last week, we spent about 8 hours in joint oversight committee meetings in Raleigh with the House and the Senate, talking about mental health and Medicaid expansion. We actually have a system now that will pay for Medicaid expansion, but the biggest problem that we have with Medicaid expansion, and that's what we're in Raleigh for, is to solve problems, is to find enough providers that we can take care of an additional 500,000 patients. If we take care of patients with high blood pressure, diabetes, and mental health, the savings in that we save from nursing home cost, prison cost, more than pays for the cost of the Medicaid. But we have to look at a lot of obstacles that we have that's preventing that. Things like certificate of need, scope of practice, cross-state licensing, and telehealth. As providers, we have to focus more on improving our patients' quality of life as well as quantity. We spend way too much time and money protecting our professional turfs. The easy part's done. We've identified that we need to expand Medicaid to improve the quality and quantity of life, and to allow people to be able to stay in the workforce longer, which is a real need today. We need to expand Medicaid to keep people out of our jails, our prisons, and our court system. It's time for all of us to roll up our sleeves and figure out how's the best solutions to these problems. We can only do that if we work together. And I'm going to take the lead from my other two presenters and turn some of my time over for question and answers, because I know there's still some out there. So I'll turn it over to Rose, and thank everybody, and God bless.
Thank you so much, Representative Sasser. Since you and Representative Insko both kept things a little shorter, we're actually now on time. Woohoo! So, and since you talked extensively about the Medicaid Expansion Committee, I'm going to kick things off with that question. It comes up every year. You know, what is the status and the prospect for Medicaid expansion currently? And how does the current time differ from where we've been for the past, I think the first time we had the option was in 2013. So we're looking at 9 years. How is that the prospect different this year?
You want me to take that answer?
And whoever
I'll
wants,
start
but if
off because
you want to give it a go.
I'll go
you,
after.
you really set it up for me. Everything's about timing. I mean, we've come through COVID. We've come through a time where the whole nation had to kind of come together to solve something that we were scared to death where we were even going to be able to solve or not. And we saw the federal government get involved, and we expanded the scope of practice in a lot of areas. And we've taken care of maybe 300,000 or 400,000 more people than we would have. We've expanded Medicaid in a lot of areas that we did through the budget. I think Representative White talked about now we have Medicaid expansion for childbearing women, that we're not going to drop their Medicaid as soon as they have their baby and so on, extend it for at least a year. So all those issues where, again, we've expanded who can give the vaccines, and it's all worked. Okay. So it's going to be easier to get to the point that we needed to get to because we've already proved that we can do that. Now, yes, we need more providers. You know, we need more health professionals involved, where it's nutritionists or dietitians, and to expand everybody's scope. Yeah, 30 seconds. You've got it. I'll turn it over. Thank you, ma'am.
We added on. We added on Representative Cunningham because she stuck her hand up, but I'm going to let Representative Insko speak first because she had her hand up first. So.
Well, thanks. I had just a question for Representative Sasser, and that is, there is a Medicaid expansion committee working now, I believe, isn't there? Mm-hmm. So we haven't adjourned the long session yet, so or started the short session. Do you anticipate a bill coming through in 2022 or 2023?
I do.
Thank you.
That is something I have not heard in 9 years of the Mental Health Legislative Breakfast. So very exciting. Representative Cunningham, you had some thoughts.
Thank you. Thank you, Representative Sasser. You know you're my good friend. But on Medicaid expansion, it was an incentive put in because of COVID. The world changed in a couple of weeks, and that incentive has made it be more attractive to us to pull down those federal resources. And we very much need them right now because we're going to have a worse need of health services because of COVID. You got long haulers, and you're going to have the mental illness aspect of it. So we would definitely be able to use that additional funding.
Mm-hmm.
Thank you.
You know, it makes me think that pretty soon we're going to see the end to the federal emergency, and all of those folks who've been on Medicaid who were prevented from being, rotated off because maybe their income rose slightly, are now going to be rotated off. Are there any thoughts about, how to help those folks, or in the interim between now and perhaps a Medicaid expansion?
Well, can I follow up on that? Mm-hmm. Well, for right now, they will remain on the rolls until it's time for them to get recertified. And once the medical emergency pandemic for us, the federal ceases, then we have a year to re-enroll people. And we could get notified in 90 days or 3 months, and they'll say, well, okay, the pandemic emergency is over. Then you start re-enrolling, and you're going to see who's going to get on and who's going to fall off. But the criteria for Medicaid will still remain.
Mm-hmm, mm-hmm. All right. Well, thank you. So the next question that came from folks who registered is, what efforts, going to Tava's point, what efforts are being made to support the growing number of unhoused citizens with mental illness? I think we've seen a huge growth in the number of folks who've been homeless during the pandemic, maybe not in North Carolina, but definitely in other states. And, what else can be done? I mean, we have tiny houses, but that's only one initiative. What other things are being done?
I hate to chime in, but I will. You all know that we had Tent City, and we still have people that are homeless down here. The affordable housing is not sufficient enough. And of course, they've said it across the country, it's not sufficient enough. But in the metropolitan areas, you're getting a lot of people that are transferred into our area because they think that services are available, which some services are available, but that affordable housing is not available. A 1-bedroom apartment in Mecklenburg County right now is about $1,400 to $1,600 a month. That might be 800 square feet. And most people that are homeless, they have other comorbidities that they're also dealing with, whether it be mental health, whether it be PTSD, whether it be alcohol, drug abuse, or other reasons, criminal records. So those aspects, those definitely need wraparound services. You can't just give somebody a house and expect them to function within 30 to 60 days. That's a long-term commitment, and I don't think that we've gotten there yet. I think we need to be getting in that space, but we have so many people that have needs.
Mm-hmm. Representative Insko or Tava, do you have any thoughts about that, or Representative Sasser?
I completely agree with Representative Cunningham. Those support services are so critical. Without those, just having a home alone is not, that's not going to help. Supports are important. And I also want to mention, tiny homes are just one piece of the puzzle. That's just one piece. We need all kinds of housing options that are available for people. And also around the Medicaid expansion, I think we need Medicaid to be flexible enough so that we can bring in more providers who would take Medicaid, and also Medicaid to be flexible enough to be able to pay for housing too. I mean, right now it is hard for Medicaid may pay for services, but in terms of housing for someone with a serious mental illness, Medicaid doesn't really pay for housing. So I know the Healthy Opportunities pilot, that's going to help a little bit. Somebody else may be able to talk more about that, but that's a pilot. But I think Medicaid, while we wait on Medicaid expansion, we need all hands on deck to start to figure out who else can we bring in and what other housing solutions are available. Thank you.
Mm-hmm. Any other thoughts, Representative Sasser or Insko?
I think this is another question for Tava. What about group homes? Have they been successful, and is that an area where we could expand?
You know, I mean, group homes definitely play a role. That we have, you know, several folks who live in group homes. You know, ideally, we would like to have on the continuum people being able to live in scattered site housing where they choose where they want to live. But one of the issues that we see is, you know, it's also still isolating for some people. Like Representative Cunningham said, if they don't have the support system, if they are not part of the community, you know, we would walk into places where people have passed out and dead because no one's gone to see them. True, it is scattered site housing, but we need the supports around. You know, group homes can play a role too for folks who have major medical conditions, who can move out of nursing homes. So that plays another role in the continuum of supportive housing. And then we need to look at other models. We really need to look at co-housing models. We really have to figure out more in terms of housing than what we currently have in our structure.
Mm-hmm, mm-hmm. Any other thoughts, or can I go on to the next question?
I would just say this is one more reason where we need to have a study group and to really look at this over a year and review what we have and what we need. So hope we'll see that.
Mm-hmm. Maybe you can write one last piece of legislation to create a study group before you go, Representative Insko.
Good idea. Thanks.
So, you know, there's been a lot of talk about supports. How do we track them? I think that's been a real issue, right? Tracking long-term supports for these folks who have long, you know, sometimes lifelong needs, and ensuring that those needs are being met as they transition from one part of their, you know, lives, from one insurance plan to another. You know, what's out there? Can anyone speak to that?
Rose, this is Representative Cunningham. The tracking item that I saw on the Department of Health and Human Services is North Carolina TOPS. It's outcomes at a glance. And what it looks at is LME, MCO, a provider agency report, as well as provider agency aggregate report. And it actually tracks outcomes. So it's actually looking at how many people receive services and some of the outcomes, whether they were back in the facility or had to go to the emergency room department or whatever. It does look at some things. But what they're using as variables may need to be adjusted, because most of the variables that I saw were not positive variables. Most of them were pretty negative for what they are using as variables in it.
Mm-hmm, mm-hmm. You know, that there's been some really interesting comments in the chats here, because as I've been listening to this and listening to your presentation, Tava, what you've got going on with Penny Lane, that's out in the country in Chatham County, but there's still a lot of need in urban areas. And someone, Alyssa Brody, noted that in Durham, an empty hotel was turned into housing for homeless by Durham. I think it was it's a Durham ministry, and I'm blanking on their name, but it's the place that's right near I-85. And what are there incentives, or could the legislature create some incentives to allow for more types of creative housing options to be created?
Yeah, Rose, if I may take just 30 seconds on that. So we are working closely with Wake County right now on looking at some urban models, similar to what we have in a rural model, like a Penny Lane kind of a concept. How can we do that in a place like Charlotte, for example? Wake County has stepped up. We are working with county government, the manager's office, in terms of looking at supportive housing in a more urban area. There are so many differences. It's one thing to do things in a rural area, but it's a whole different ball game in terms of looking at safety, transportation, all those things. So our goal is to be able to work together in partnership to be able to do this with county governments. I think we need to bring in beyond DHHS, MCOs, but we need to bring in the county governments. We also need to bring in, I think a critical part is we need to bring in people receiving services onto the table to lead this. Peer support is incredibly important to be able to bring in here. That's how we are sort of working on Penny Lane. But in Wake County, I think that's where we are starting. We have peers and Wake County government working in partnership, the Center for Excellence, and a few other groups to put this together. It's funded through a Robert Wood Johnson Foundation project called Familiar Faces. These are people in and out of jail, in and out of prison, in and out of hospitals and emergency room. The system has failed them in some ways because we have this very choppy way of caring for people. How do you really integrate all of that, but sort of build that from ground up? I'm happy to send more details on that, but it's a initiative through Robert Wood Johnson Foundation to build a team together, bringing in different systems together.
It's interesting, Vicki Smith, who knows more about mental health services who's forgotten more about mental health services than I'll ever know, noted that DHHS is currently working on a 5-year housing plan. Another one of the comments from the chat talks about zoning, right? And, I was thinking about Penny Lane, Tava. I think one of the advantages you had in Penny Lane is that when you started it, you were kind of out in the middle of nowhere. And so you probably didn't have to deal with some of those NIMBY issues about bringing housing for people with a mental health disability into, a neighborhood. What are some ways that we can get over some of those hesitations that people have?
Yeah. Again, I'll take 30 seconds. Penny Lane is surrounded by $600,000-$700,000 homes. We have NIMBY issues. You work on a daily basis on that one. We make Penny Lane attractive. Penny Lane is not just for people with serious mental illness. We have veterans involved. We have schools involved. There is no stigma. We want to make sure that nobody is a patient or a client. Everybody is a volunteer. So when people come in, I think it's critical as leaders or people who are working in this field to be able to normalize mental illness. We would hear someone come and say, hey, this will take a while, but we'll come and say, hey, my brother has a serious mental illness. So we need to normalize this one. So we do not want to segregate people in any way, but we need to create opportunities out there. So we have university students who are doing their projects out there. We have a therapeutic running farm that's working there. So I think bringing in different people, we have to be part of the community where the community is in there and normalizing it and not segregating it. That is a tough job. It's a balancing act that we have to do, but I think it can be done.
Mm-hmm. What kinds of role can the legislature play in perhaps incentivizing these? Representative Inscoe or Representative Sasser, do you have any thoughts? Oops, Representative Inscoe, you're muted.
I just said I apologize. I've been reading some of the comments, and so I missed the question.
Oh, so the question I have is like, what kinds of incentives perhaps can the legislature, create in order to help overcome some of the barriers to creating housing opportunities for people with behavioral health issues?
Well, I think there are things like tax credits that if a developer wanted to work on that, or even a nonprofit wanted to do some of that.
Mm-hmm. I hadn't thought about that. Do you have any thoughts along those lines, Representative Sasser?
No, ma'am, you've kind of caught me off guard, but I will I will definitely check into that and see if we have anything available.
Well, I think that's part of what this breakfast is meant to do, is to give ideas to legislators.
I'm in on it, Rose. I think, when you start saying the state, we do a lot of what, certain states don't even provide as many services as we do. And because we're here, we don't even realize it. Mm-hmm. But the counties also own some of their own property. And I think that doesn't have to come through the legislature, whether the county sells a piece of property and go in partnership with an entity that's going to assist the county to better themselves in the quality of life. So mm-hmm. sometimes it takes a different kind of partnership, and the state doesn't necessarily have to be involved with it. But there are some incentives to doing it if you have to bring the state in to do some of the financing.
Mm-hmm.
Rose, also, I'm sorry, I was going to say just quickly, 10 seconds. City governments are changing also in terms of how they're looking at zoning. So that's a very favorable change. Like Durham has done some amazing work, the city of Durham, in terms of changing the zoning rules around willing to accommodate now like smaller homes, what we used to call granny pads, right. Being able to do that in a bigger lot where you can build a smaller home. So there are some changes that we are seeing even within city governments and county governments to change zoning laws, because it is a crisis. I mean, as you know, housing is a crisis right now everywhere, especially for people with special needs.
Mm-hmm. And then finally, just to sort of wrap things up, Max, who is our organizer of this whole event, he made a really great point that perhaps about using like an HIE, a health information exchange, to track the long-term supports to make sure people are getting them. We're going to be seeing some of that in the Healthy Opportunities pilot. So it'll be really interesting to see how well these things get tracked and how well these things or then be able to be addressed because of that. Tava, how do you folks do long-term tracking for your clients?
Yeah, so I mean, it's being part of a larger organization, we have several services. People move from place to place. Obviously, there are choice. I think that's critical for the person. But generally, when somebody gets used to a psychiatrist, for example, things are working well. You don't want to artificially move people because their authorization has ended. So I think we are kind of blessed in that way. We are able to keep those kinds of connections going, and being able to track with larger systems like Epic, for example, which large hospital systems have, larger medical records, a lot more easier to track systems. I think we need a unified system. I completely agree with Max in some ways, so that people don't get slip through the cracks here, because it happens all the time, because we would then see somebody in the correction system showing up, and then we don't have a way of knowing what happened to them. So I don't think we have the perfect system in place, but larger systems do have things like Epic that we are able to track people that is connected. I believe 60% of the hospital systems in North Carolina now use Epic. So that is a way for us to be able to kind of track things, but I think we need a more unified system where smaller providers, anyone should be able to figure out a way to track people. Kind of like the NCCare 360 that is meant not just to track, it's just to make the referral, but some sort of a system like that everyone can have access to.
Well, with that, we are coming to the end of our morning. Again, any one of these panels, we could have gone on for a half hour with Q&A for any of them. Before we cycle away back to Senator Woodard, I would like to extend a thank you to Kay Castillo from the National Association of Social Workers and Corey Dunn from Disability Rights for their assistance with compiling, taking all the questions that we received and boiling them down into a very pointed and focused group. So thank you so much to Kay and Corey.
Another great panel, and thank you to Verlin, Wayne, and Rose. Thank you for all your support for many years here and doing such an incredible job for us. And if you don't have North Carolina Health News bookmarked in your web browser, you need to go do that right now and read it every day. Rose, thank you for all the great work you do every day.
Thank you, Senator Woodard. Really appreciate that.
I think Victor started this, but I didn't know if Wayne or Carla was going to out-country the other one or not. I just, y'all were getting real country on me there. Some of us did know how to slop hogs, wring chickens' necks, and prime to back. I just want to point that out. It's been an incredibly great morning for us again. Like I said, we're always fitting 12 pounds in a 10-pound sack. So thank you all for being here. Thanks to all of our speakers, all of our sponsors. We could not do it without your support. Our great friend Josh Lozoff, who did an incredible magical entertainment for us during the orange juice breakfast, and to all of you for participating. I think we got up over 250 people today, and that's just incredible participation. Don't forget to save the digital program that you received in the mail. It's got information on how to contact all of your elected officials, those of us at the state level, and of course your local elected officials as well. Don't forget the role they play in providing mental health services, especially on the housing question. I got to stop for a second and say, let's hope that we'll use local officials to work on a lot of these housing solutions as well. And of course, there's information on how you can maybe get Josh Lozoff to provide your own magic show. So check that out on the program. And remember, the breakfast has a website and a Facebook page they keep up throughout the year. So be sure you look at those and visit them from time to time. And don't forget, mark your calendar for the 45th legislative breakfast. That's going to be February 25th, 2023. Fingers crossed we will be back eating that great breakfast at the Friday Center, and we'll all get to see you in person next year. Thanks again, everybody, and have a fantastic day.